like Doctor.
Sir, good morning.
Am I clear? How is the quality of my voice?
Perfect. Yeah, good, sir. I can hear it.
Thank you. Thank you very much.
Are we live? Right. Good morning, everyone. It gives me great pleasure in inviting you all to this Medicolegal symposium on for orthopedic surgeons and doctors at large. I am Dr. Srinivas Kasha, TCOS, Twin Cities Orthopedic Society Secretary, and it is our President Dr. Somashekhar Reddy's vision to have academics and off-the-track programs like this for the betterment of orthopedic surgeons. And last time we have conducted happiness workshop, which was really a great success. And this program is organized by TCOS and TOSA, Telangana Orthopaedic Surgeons Association. I would like to invite Dr. P. Sudhir Kumar, President of Telangana Orthopaedic Surgeons Association, to give a small message.
Good morning, everybody. I'm Dr. Sudhir Kumar, talking from Warangal. Is here since morning. There's a huge rain, and this I appreciate Dr. Srinivas Kasha and Dr. Somashekhar Reddy sir for organizing this.
Dr. Sudhir, you went on mute somehow.
Oh, sorry. Good morning, everybody. Today is a rainy day in Warangal, and I appreciate Dr. Srinivas Kasha and Dr. Somashekhar sir and TCOS team for organizing this webinar on medical legal aspects, which is very important in day-to-day practice, as every patient has become a litigant. Every patient expectations are very high, and when the time comes to the patient comes to the hospital, you would have visited his local RMP and his relatives or a distant doctor, consultation, teleconsultations, and everything. When he finishes, he comes to the doctor for physical consultation, and by that time everything will go wrong. And when we treat such kind of patients and things don't work out, they start blaming the doctor. And these kind of webinars are very important. What kind of precautions we have to take in preventing such kind of litigations. I appreciate the efforts of TCOS and TOSA for these kind of webinars, and congratulate all the faculty for being a part of it. Thank you.
Thank you so much, Dr. Sudhir. And so let me.
I can show you the kind of rain here going on.
Right. Thank you, Dr. Sudhir.
Okay, right. Going on.
Yeah. So let me just introduce faculty. Dr. K. Krishnaiah, although he is a very busy joint replacement surgeon, he has a special interest in medico-legal aspects, and he keeps educating us at KIMS. I am part of KIMS, where Dr. Krishnaiah also works. He holds a law degree to his credentials, and in fact, he is instrumental in designing the whole program of today's event. Thank you so much, sir, Krishnaiah sir, for accepting the invitation. And we are lucky to have Mr. E. Damodar, IPS police officer, who is retired IG. And thanks for accepting our invitation, sir. And we have Professor Madabhushi Sridhar Acharyulu, Dean, School of Law, Bennett University, and ex-professor of Nalsar University of Law in Hyderabad. He worked as an Indian Academic and Information Commissioner from 2013 to 2018. Thank you for accepting our invitation, sir. And we have Dr. Neeraj Nagpal. So all, not only orthopedic fraternity, all the medical fraternity knows him. He is a gastroenterologist by profession. He has enormous knowledge in medico-legal aspects and a reputed speaker across India. We have Dr. Nikhil Shah, a consultant hip surgeon from Wrightington Hospital, UK. In spite of his very busy schedule and odd timings, he has accepted to be here. He is going to join in between around 10:40. Sir, with this, I'd like to request Dr. Krishnaiah Garu to take over and then give the introduction. That is first part of the talk. Over to you, Krishnaiah sir.
All right, Kasha, thank you very much indeed. Let me just show a few slides on this introduction. This has been an addition to me yesterday evening because, sorry,
Yeah.
no, that's not the one. Because the talks are there is small change in the talk in the sense that Dr. From the UK is supposed to be the first talk, and we were expecting some kind of introduction on this talk before we go on to speak various subtopics. Therefore, Kasha has asked me to throw some light on the introductory point of view of medical negligence and how the law perceives and where we are now. So let me go through just a few words about what medical negligence happening. It is an emerging issue in India. We all know that, and in fact, it's worrying issue to us. A while ago, this is medical negligence have never been heard about. Therefore, doctors were free to go ahead and do the treatment without any threats. But now, with the advancement of medicine, but that means a lot of private investment and a lot of cost. Therefore, this cost has to be passed on to the patient, resulting in patients paying huge bills. Look at this, 13% of household expenditure and 59% either borrow or sell their assets to pay for health. Now, undoubtedly, I have no hesitation in saying that there is a business attitude of hospitals, second doctors. It is business now. We employ marketing people, we sell our services, and therefore, in that process, resort to all sorts of practices like commissions and brokerage, which is never heard about. So with this kind of attitude, now it's no different than service for money. So when you have provided service for money, you're liable for deficiency of services. And therefore, in 1986, medical services is included in along with the consumer services. And therefore, it is no different than other service and liable for litigation. Now, healthcare in India, needless to say, is very poor compared to all the developed countries. We spend very little on that, government in particular, and 70% of patients go to private hospitals for their healthcare. They spend out of pocket money and therefore often results in poverty in India. One unexpected admission can wipe off 60% of an average person's earnings. So this is a very, very alarming situation. Well, ladies and gentlemen, COVID, last 1.5 years, we've been talking about this. And it really wiped off and disturbed and destabilized many families. And there is some truth in that doctors and hospitals have put in very high billing and therefore attracted wide criticism by the public, politicians, press, and even courts many times have involved and interfered and then pressurizing the governments to bring new regulations. Very soon you will know that Telangana government is planning to put in another bill to curtail. Already so many government orders have been issued to curtail the billing. So that resulted in general public, although, on the face of it, people say doctors are gods and warriors, etc., etc., all sorts of words being given, but the ground reality is this has definitely put deteriorating trust and confidence on doctors, especially. So now, ladies and gentlemen, please beware. There is more scope for litigation. What is this litigation? Negligence? Well, briefly, it started in 20th century, and look at that, 120 billion awarded for birth trauma, 103 million for cerebral palsy. In this country, 6 crores have been allocated in one case, and another case in Nizam's hospital, negligence was proved, and 1 crore was allocated. So it is increasing. Basically, what the medical negligence is, please look at this statement that sums up everything. The doctors owe a duty of care to their patients, failure of which in medical treatment resulting in death, injury, or pain of the patient gives rise to cause of action as it constitutes negligence. So that duty of care, we all have to understand and provide to the patient. If there is any deficiency or imperfection, then that results in cause of action, a litigation, medical negligence. Because consequences of medical negligence are disproportionately dangerous and often cannot be quantified compared to other types of negligence. Look at this orthopedic example: screw passing through a vein. Well, once it is thought of, patient has multiple options. It can be prosecuted under tort. This is a worrying thing. In the United States, negligence is processed under tort. Tort has unlimited liability, unlimited liquidation. That means the consequences of damage are enormous. There is no predetermined. And as a contract also, because the contract exists between the patient and the doctor, therefore breach of contract can be prosecuted on that. But more worrying is the crime, or where doctors could be arrested. Under consumer law, we all know that, where of course compensation. So to talk about it, we brought in an expert, as Kasha said, my dear friend, Mr. V. Damodar, who has extensive experience and as a top lawman, retired Inspector General of Police, and he's going to throw light on why and when doctors have a threat to be arrested. But criminal negligence, mind you, requires a very high standard of negligence, very high degree of negligence. And it says that recklessness and indifference to the consequences of action, although known about. So that is criminal negligence. And we also brought in a great intellectual person, Professor Madabhushi Sridhar, to talk on the civil liability for medical negligence. I mean, people who are worried, the medical fraternity, very worried and upset about including medical negligence into the Consumer Act, along with deficiency of service in purchasing refrigerators, televisions, etc. But all sorts of arguments have been put in, and Supreme Court has set aside and clarified it in Shanta case. So on that, Professor Madabhushi is going to talk about it and give us some knowledge on that topic. Thank you very much.
Thank you very much, sir. Without any delay, the next talk is by Dr. Krishnaiah Garu on informed consent, which actually I am just playing the recorded video.
So
is that okay for you, sir?
Talk about it. It's already recorded.
Yeah.
All right, Kasha, go ahead.
Great, thank you, sir. Let me just share it. Can you stop sharing, sir?
Oh, 1 minute. Stop share. Okay. Is that okay? Good.
Yeah, great. Thank you, sir. Is that visible, sir?
Yes, of course.
Is it?
Ladies and gentlemen, at the outset, I'd like to thank Dr. Kasha Srinivas for asking me to speak on this topic.
Increase volume.
I also want to congratulate him and appreciate him for choosing this topic, which is very relevant at this stage, especially after COVID, where the criticism on doctors and hospitals is ever increasing. Well, you may wonder why I am asked to speak on this topic. I'm not a practicing lawyer. However, I do have a bachelor's degree in law from Osmania University. I also have a postgraduate diploma from Nalsar University. And as part of that, I submitted thesis in medical negligence. So I suppose I do have some knowledge on this, and that is the reason why Kasha has picked me up. And during this, my guide and advisor for this thesis was Professor Madabhushi, who is a well-read man, an outstanding law person with tremendous amount of knowledge in the country, and recently retired as Commissioner of Information. And he has kindly agreed to come and give us his thoughts in this topic. Well, for millennia, medical treatment has been, medical profession has been considered as a noble profession, and doctor has been regarded as next to God. And of course, the physicians have treated the sick with compassion, kindness, and very rarely money, question of money, payment, etc. have come between the patient and the doctor. Whatever the physician felt appropriate in the best interest of the patient, he has done that. And that has never been questioned. He never asked for permission. But that is changing now. For the last 100 years, this concept of consent has come up. First in the United States. Way back in 1914, the Supreme Court Justice in the US has said this. This is the core rationale of consent. Every human being of adult years and sound mind has a right to determine what shall be done with his own body. It's his body, so anything you want to do on his body, you need his permission. That is consent. Therefore, it is necessary to have a consent before you commence the treatment. During the Second World War and before that, the Nazis have done all sorts of atrocities on prisoners, various unkind, inhuman experiments on Jews. And therefore, at the end of the war, in the Nuremberg Code, it was incorporated that anything you want to do on patient, you need his permission. Again, on the same note, in 1964, the World Medical Association has declared in Helsinki that consent is mandatory. So it stands now, it is mandatory to obtain voluntary and informed consent of human subjects before treatment. And this importance of consent is otherwise right of self-determination. What is this self-determination? Please understand that a competent adult is entitled to reject a specific treatment or all treatments, or to select an alternative treatment, even if the decision may entitle risks as serious as death and may appear mistaken in the eyes of the medical profession or the community. This is self-determination. You may think that he is stupid to make the decision of refusing the operation or going for another operation, but it is his body at the end of the day. This is what calls right of self-determination, and it is part of fundamental right guaranteed in Article 21 of the Indian Constitution. Even Medical Council of India Act in 1956 also incorporated in the Code of Ethics and clearly states that before performing an operation, the physician should obtain the consent in writing. So what does this consent? Well, it's a process of communication between a patient and physician that results in the patient's authorization or agreement to undergo a specific medical intervention. So this dialogue, this process between the patient and doctor will ultimately result in the patient giving permission or his approval to subject himself for the treatment that's proposed. Interestingly, it is defined in Indian contract in section 13. It says 2 or more persons are said to consent when they agree upon the same thing in the same sense, otherwise called meeting of mind. They all have to understand each other and agree upon it, then only you call it as consent. Well, what is Indian Contract Act to do with medical profession? Yes, please understand that the relationship between a medical professional and his patient is a contract. In contract, one essential ingredient is consideration. Here, patient fees. What patient is paying is consideration. When he pays fees, he agrees for the treatment, and the doctor is supposed to give the treatment, quality treatment, a careful treatment, failure of which can result in litigation. So if we didn't give consent and proceed to totally disregard to consent and proceed to treatment, he might end up in litigation, the procedure done without permission. So the doctor who proceeds to disregard the requirement of obtaining consent is strictly liable for any untoward consequences resulting from the procedure of treatment, even if he conforms to the accepted medical practice. Look at this illustration in here. Patient with fracture dislocation of the ankle consented for setting the fracture, manipulation and anesthesia. After setting, obviously the reduction was not adequate and ankle was unstable, and the surgeon proceeded to do this wonderful operation, best operation, but patient did not give consent for this. He could object to it, and technically you call this as battery because you have cut open the patient's leg without his permission. Various types of consents are available. Out of that, the best consent is the written consent. Best form of consent is written consent. And it is, of course, mandatory for all major procedures. When there is litigation, if you have a written consent, it's easier to prove. But before you get this, please provide all relevant information relating to the proposed treatment to the patient in a language understandable. It's very important. There's no point in giving a big form in English without where the patient cannot understand. The best thing is, like here, Kims design their own forms explaining all the details, and there are, as you see, columns to be filled, name of the operation and the complications, etc., etc. They should be filled by the person, doctor who is taking the consent. Preferably, as you see in here, in the local language, which is easily understandable. There is another consent called explicit consent, where it is stated in distinct and explicit language. It may be oral or written. You say something to that, but patient not necessarily in writing, he agrees to it. He expresses that. He approves the consent. It's usually applied for minor examination or therapeutic procedures. It is as valid as written consent, but the written consent, of course, has advantage of easy. When the treatment is likely to be more than mildly painful and carries appreciable risk. One more type of consent called implied consent, which means that an implied consent is a sign to examining his body, although he has not said go ahead or giving in return, he has not refused the examination. Therefore, it is implied that he has given consent. But be careful. During the clinical examination, if there is a requirement for intimate examination of the patient, such as an internal examination is needed, orthopedic surgeons rarely require to do internal examination. But in case, you must obtain another consent by asking the patient's permission only. Especially if there is a need to undergo a procedure such as drawing of samples of body fluids like aspiration of a joint, a written consent of the patient is ideally required. So this informed consent, what we have been talking about, what is exactly the informed consent? Well, in informed consent, a doctor's duty is to inform the patient of the advantages and disadvantages of undergoing the treatment proposed, and particularly to inform the patient of the risks involved. That's doctor's duty. A conscious adult patient of sound mind is entitled, after having received the information, is entitled to decide for himself whether or not he will submit to a course of treatment proposed by the doctor. So the two parts are important. Doctor's duty has to be done. Then it's up to the patient whether to go ahead and accept or refuse. So that is informed consent. So therefore, the right to decide the manner in which his or her body treated lies with the patient, the core concept of consent. The onus of disclosure of information lies with the doctor. You have to do that. And the decision maker, that's the patient, must have knowledge about this procedure, must have knowledge of risks and potential benefits of the procedure before he makes the decision. What is this knowledge? What type of knowledge? Well, all information should be explained in comprehensive, non-medical terms, preferably in patient's own language, about the nature of the illness, nature of the proposed treatment or procedure, or any alternative procedures that are available, and risks and benefits involved in both the proposed and alternative procedure. Potential risks of not receiving the treatment also has to be mentioned, and relative chances of success or failure of each procedure. This discussion, this knowledge giving to the patient, and then obtaining his permission after evaluation by the patient is the informed consent. So then, well, how much information you can disclose? What is sufficient? Can you tell everything? For a local anesthesia procedure, risk of death, maybe 1 in 10,000, 1 in a million, can you do that? The answer is like this. Patients have right to information, including options. We know that. The amount of information given should include the nature of the condition, the complexity of the treatment, the risks associated with the treatment procedure. Risks, yes. How much you can withhold? Well, again, information necessary for decision making should not be withheld unless it is judged that the disclosure of some relevant information would cause the patient serious harm. For example, emotionally imbalanced patient may get very hurt, may get jittery if you say there is a small risk of death or small risk of nerve damage. And such condition, which is highly unlikely, you may withhold because of the patient's nature. So this withholding information, otherwise called therapeutic privilege to the doctor. A physician may legitimately withhold information based on sound medical judgment if he feels that the information may have potential harm to a patient who is emotionally depressed or unstable. So if you strongly believe that that might cause harm, you may have this therapeutic privilege of withholding some information. So the disclosure of information or withholding of information, various nations have various views. In USA, they believe in giving maximum information because giving maximum information in informed consent will bail you out, will put you in less chance of litigation. They also believe that consent without necessary information is no consent at all. So the informed consent doctrine, it is an American in origin and relates to the amount of information that a patient should be provided with to avoid any probable action negligence. You know that these medical legal issues are very prominent in the United States, and the highest compensation for medical negligence was 110 million some years ago. So it has such a frightening, especially in certain specialties in medicine. So everyone talks about medical negligence and scared about medical negligence. Whereas the English courts are more liberal. Lord Templeton says the doctor, being a professional man, should be bestowed with the final right to decide what and how much information shall be divulged to the patient. Give reasonable freedom to the doctor to make a decision regarding the quantum of information given to the patient and how much he can withhold. But what is the Indian view? Well, at the moment, there are no clear parameters laid down by the courts. However, it is reasonable to withhold information which a doctor deems fit, considering the best practices and in the best interest of the patient. So if you understand those two, so it's a little vague and broader kind of view, but you have to keep this in mind when you make such decisions. When is the consent is valid? Well, please remember the consent, the free will should be free and voluntary. It should not be obtained by coercion, fear, influence, fraud, misrepresentation, mistake, or canvassing. Many times we try to convince the patient by canvassing, which I don't think is the right thing. You should be given a free will. Consent should be given a free will. Who can give consent? Well, person who has capacity and competence to give consent is the adult person more than 18 years of age with sound mind. If the consent is obtained while the patient is under sedation, it's not valid, because many times we see that in the case sheet before surgery, the consent is missing, and therefore go and get patient signed on a piece of paper. By the time he is already under the influence of sedation and pre-medication, etc. And giving consent at that type of mindset is not the right consent because he's under sedation. Who obtains consent? The doctor providing treatment or undertaking an investigation is the best person, whereas if it's not practicable, could be delegated to a suitably trained and qualified person who has sufficient knowledge of the proposed investigation or treatment and understands the risks involved. Not by nurses. Many times we get by nurses, which is not right. Nurses don't know the full nature of the operation and the risks, therefore they cannot explain to the patient. Whoever takes it, please remember, you are accountable at the end of the day. And the consent also should be procedure specific. The Supreme Court of India called it paternal doctor. That means he has given a consent for broad, blank check type of consent. Consent given for a specific treatment procedure will not be valid for conducting some other procedures. In this case, a doctor was found negligent for performing oophorectomy during this treatment. An additional procedure may be performed without consent only if it is necessary to save the life or preserve the health of the patient. Please remember that it is absolutely mandatory and necessary, then only you are allowed. Sterilization operation done during cesarean section without consent is not an urgent procedure. So the doctor was found guilty in this case. So when do you have exceptions to obtain consent? Well, in emergency treatment. A doctor can lawfully operate on an adult patient who is incapable of giving consent if the surgery is done in the best interest of the patient to save life or limb or to prevent deterioration. Here is an example. Patient was brought into emergency room, unconscious, with terrible wounds like this, bleeding, and there is threat to life. And the doctor went on to do this amputation to save the patient. 20 years ago, it was me. Luckily, nobody complained, although they were very upset that the 18-year-old girl lost her leg, but the circumstances they understood. There you have, even illegally also, you have exception. So in emergencies, a patient was admitted into hospital diagnosed as perforated appendix with peritonitis requiring an operation. The operation was not done because of want of consent and the patient died. The Kerala High Court held the doctor negligent because you don't need consent in emergency situation. This is the concept that is also incorporated in IPC 1860. Act done in good faith for benefit of person without consent is not illegal. For example, Jed fell off his horse and is unconscious. A surgeon finds that Jed requires craniotomy. Jed died during surgery. A not intending Jed's death, but in good faith for Jed's benefit, performs the surgery before Jed recovers his power of judgment for himself. Here is the doctor is not dead. So Lord Donaldson sums it up in emergencies. A patient's interest consists of his right to self-determination, we know that, whereas society's interest is in upholding all human life. In a situation of conflict of the two, of course, the right of individual is paramount, that's his body. But where there is in doubt, it resolves in favor of preservation of life. Well, we have special problems in India regarding consent. This medical negligence is an emerging issue. Well, fear of patient going to others, we withhold information. Patient is illiterate, we don't tell them everything. High unrealistic expectations, so we tend to give unrealistic assurance, 100% sense. Professional rivalry. Patient may go somebody else for surgery, so we try to convince. And these are problems, but still, please understand what lies are. Let me sum it up with this statement about consent. A competent adult is entitled to reject a specific treatment or all treatments or to select an alternative treatment, even if the decision may entitle risks as serious as death and may appear mistaken in the eyes of the medical profession or the community. That tells everything. Well, doctors have been considered as next to God. Next to God as long as everything is fine. If something goes wrong, this is the view taken. A doctor is supposed to get rid of pain, but not to cause it. That's the source for medical negligence. Thank you very much.
Thank you so much, sir. That was a wonderful talk. So before we are just waiting Nikhil Shah to join. Before that, I'll ask one question, sir. What is the right time to take a consent? That is, say if I'm posting somebody for surgery tomorrow, which is an elective surgery. And, although patient comes in OPD, I tell him everything. but the documentation or a signature of the consent, or whatever that is explained, will be available only when the patient gets admitted and the case sheet is present, which happens the next day. So is that okay, or we need to take a consent in OPD itself?
Yeah, okay, Srinivas. Yes, in England, I mean, sometimes they do in the OP because once the hip replacement is scheduled, everything is explained, because that's where the consultant has time to explain and give the real informed information regarding the surgery, pros and cons, complications, etc. And it gets signed at the time. I mean, if the operation is going to be done shortly, I would say in 2, 3, maybe a week, that consent, in my opinion, is valid. But you can take, few hours before the operation while on the ward. The best time is ask you yourself, preferably, or your assistant, go to the patient and talk to the patient and explain in detail, and write the name of the operation yourself. Also write name of the complications, most of the complications, especially serious complications, and explain the operation, get the signature. Please do not leave it to the nurses. That's what we do. Even repeatedly saying this, still we get nurses to ask the patient to sign. And it's very unfair because nurses cannot explain the operation. And they get a signature many times even without filling the name of the operation and the complications, etc. The worst thing to do is in operation theater just before going to operation. Patient is very apprehensive, and I would say it's he's under pressure and is rather compelled to give consent. I would regard that, is forced to do that consent. It's not fair to do that. And worst is to get a signature after the patient is pre-anesthesia medication given, like sedation I mentioned in my slide. So it's okay as far as I'm concerned, and it's being practiced in the UK, which I've seen, where consultant gets consent in the OP, but the best time is on the ward. You just at the same time ask the patient which side. You make a big mark. In orthopedics, we have 2 sides, left and right. So you put a mark, you write right hip replacement, and then get all the signature done.
So there is a question. Yes, sir. Thank you, sir. There is a question from Dr. Neeraj Nagpal. Do we need informed consent or real and valid consent in India as of now?
Of course you do. I mean, there was a paper you sent the copy to me yesterday. In fact, the courts, the National Forum has gone to such an extent. There was a consent, and the forum considered that the consent given was a broad consent, and hospitals are exploiting by putting printed forms without giving scope for writing details, etc., etc. That itself tells that, the consent has to be specific to the procedure, and it should be a proper consent. And tomorrow, if patient takes a plea saying that I was forced, I was convinced, I was asked to sign here, although there is a signature for the operation, still the validity of the consent is questioned. So therefore, you need a valid consent. A validity, should fulfill certain requirements. And again, many times we see patients signing for everything. Paternal doctors. That means you sign. That means given a blank check, freedom for the doctor to do everything. I don't think it's fair either. The patient gives consent to a particular procedure. However, having said that, during that procedure, if you want to deviate slightly this way and that way, like patient has signed for nailing of tibia, and during the operation or at the time you may make a change in saying put a plate. I don't think it's grossly wrong, because based on the clinical situation, you may, that is acceptable. But if patient has signed for fixation of the fracture, you don't bring out the patient from theater with a hip replacement. That's, I think, gross deviation. That should have been discussed. Yes, sir. Nagpal.
So number one, the judgment of RG Stone Clinic, where this pre-printed consent decision was given by National Commission, has been overruled already by Supreme Court.
Yep.
So that judgment is no longer valid. Number two, these are two totally different types of consent. One which is called informed consent, the other which is called real and valid consent. Real and valid consent is the UK formula which we are following now in India. Informed consent is the US concept which we are not following as of date, but we may be shifting towards that gradually over time. Because even in UK, they are now gradually shifting to the informed consent type. The discussion will be too long, so I will not.
Yeah, just let me sum it up, Ed. Now, the very fact that a very high legal body like National Forum has done that. Of course, I mean, on a technical ground, Supreme Court has overruled. I entirely agree. But that gives an assertion, that gives an impression, the importance given. So therefore, we have to be aware. And again, you know, like I said, Britain has been fairly liberal, but they are again for the having experience in litigation. I remember shoulder arthroscopy. One of my colleagues who was doing, he mentioned risk of death in that. There was a lot of debate on that in our audit meetings. And finally, he said, look, it is a fact, it may be 1 in a million doing shoulder arthroscopy resulting in death, but for his sake, they complete. I think the point is that we are moving it. So get as much as possible. That's the point. Thank you.
Thank you so much, sir. So we are talking about British concept. Now we have Dr. Nikhil Shah from Wrightington Hospital, UK. And good morning and very warm welcome, Dr. Nikhil Shah. Thank you very much for accepting our invitation in the odd hours.
UK, Nightingale Hospital.
Can you hear me?
Nikhil Shah.
Can you hear me?
Yeah.
Okay.
So,
shall I start my screen share?
Oh, yes. So, Dr. Nikhil Shah is consultant hip surgeon at Wrightington Hospital and has got a vast experience, and he gave many talks in medico-legal aspects. And so over to you, Dr. Nikhil Shah.
Can you see the screen?
Yes.
Okay, can you see that? And you can hear me?
Yes.
Right. Good morning, everyone. I'm sorry if I'm speaking a bit softly. I'm in a hotel room, actually. I'm on holiday with my family in Scotland. So the topic that was given to me was medical care and negligence. And I'll talk a little bit about my ideas of consent. Sorry, the screen is not moving forward. So in this talk, I'll cover some basic principles and laws, including the Bolam test and the Bolitho, then a recent judgment called the Montgomery judgment that changed the way consent was legalized in the UK. I'll cover some common reasons for litigation in orthopedics with some case examples, and then a few words on how to prevent litigation. So the Bolam principle is quite an old principle, and I think the Indian courts also use this. A doctor is not guilty of negligence if he has acted in accordance with the practice that is accepted as proper by a reasonable body of medical men skilled in that art. So for example, if there is a particular way in which you do your intramedullary nailing, but there's a reasonable body of medical opinion that also does the nailing in that particular way, then you are not considered as negligent. Now, this judgment had to be refined with time because you can always find a body of people that might do things the way you have done, or that might not do things that way. So the Bolitho judgment said that when there are two opinions, the judge can choose that opinion that is logically defensible. In other words, if there are differences of opinion between two bodies of doctors, but one is less logically defensible and the other one is more logically defensible, then the judge will be entitled to choose that which he thinks is logically defensible. And basically that means something that is supported by evidence. So long as the alternative opinion is evidence-based, then that is reasonable. The Montgomery case changed everything in the UK, and it shifted the balance of power in consenting from the doctors to the court. So up till this time, if there was a case in relation to negligence in consent, the doctors could decide if that consenting was reasonable or not. In other words, if someone has consented for a hip replacement and has mentioned or not mentioned death, if so long as a reasonable body of doctors think that not mentioning death was acceptable, the court would not overrule that. The court would then consider that, okay, this is acceptable practice. But that power was shifted from the doctors now, or your peers, to the court. It's interesting to understand what this case was. So Nadine Montgomery was a diabetic lady. Diabetic patients have got larger babies, and there is a risk of shoulder dystocia. This obstetrician routinely did not advise patients of this risk. Now, even when this happens, the likelihood of a significant complication like hypoxia was quite small, 0.1%, and brachial plexus injury, 0.2%. So this doctor felt it was not necessary to advise of this risk, because if done so, all the women will choose a cesarean section. So basically in this particular case, the option of a cesarean section was not discussed, and unfortunately, hypoxic brain injury occurred during the normal delivery, and the baby was born with disabilities. So the mother obviously said that she had been explained the risks, she will have chosen a cesarean section. Now the original decision when this case went to court relied upon the Bolam and something called the Sidaway judgment. And based on that, there was a reasonable body of medical opinion who felt that this obstetrician has not acted inappropriately. And so the case was actually dismissed. Montgomery then went all the way to the law lords. So this is a bit like the Supreme Court, okay? And this case became quite well known in the UK, and then the GMC also contributed, and a lot of other important bodies were invited to give their submissions. And so the courts then concluded that the Bolam principle in this case was satisfied. But patients have got rights to choose. They are not just passive recipients of care from the medical profession. So the Supreme Court accepted that if this lady was properly warned, she would not have agreed to undergo induction of labor, and therefore the court found in her favor and she was entitled to damages. So basically the Montgomery judgment came out and said that the patient should be made aware of any material risks that are involved in the recommended treatment, and that the doctor should also make her aware of reasonable treatment alternatives. Now, what does material risk mean? Material risk is something that the patient will find significant enough to make a decision. So for example, if you're doing a hip replacement, some patients may not feel that leg length inequality is a material risk. Some patients may feel that a leg length inequality is a material risk, and the same will apply for death or any other risk. And it is the doctor's duty to know what the material risk will be that that particular patient might want to listen. So basically the emphasis shifted completely from doctor delivered consenting to what the patient wanted to know. What should a reasonable patient want to know and choose her or his treatment? The other thing that the Montgomery judgment came out is treatment options. So when a patient comes to you with arthritis of the hip joint, it is not sufficient to just tell him that you need a hip replacement. You have to give him all the reasonable treatment options, including the option of doing nothing. The patient can then choose that he does not want anything doing, and he can choose to live in pain of the hip joint, or he might want to take a diagnostic injection, or he might want a hip replacement. Now, if there are multiple types of hip replacements available, then it is the doctor's responsibility to explain that there are these 2 or 3 types of hip replacements available. So when the Montgomery judgment first came, doctors were quite worried because this was like a turning point in medical litigation in the UK. And this was the beginning of the end of the Bolam test. So this no longer became a matter of expert opinion, but the court started deciding what is reasonable in terms of consent and not the profession. Now, it is not enough just bombarding the patient with information. So people came up with the idea, let us prepare documents wherein you explain every conceivable risk in the book and the percentage attached to it, give it to the patient, you read it and you sign it. That's not informed consent. Informed consent is a dialogue between the doctor and the patient. Consenting is also not satisfied just by obtaining a signature of a patient on a consent form. The patient genuinely has to understand what they are signing for. In fact, the only value of a signed consent form is that it is just a piece of paper with a signature. It really has no value anymore. Now, these concepts were not new concepts. They were already present in some older documents that the GMC had got out in 2008 and 2009. So what the court did effectively is just confirmed that whatever was in the document anyway just has to be now converted into law. Okay, so that is about consent. Now, what are the common reasons why doctors will be sued? Consent issues is a very common reason why doctors are sued. Then the other common reasons I see in my medical legal practice is missed diagnosis or delayed diagnosis, delayed treatment, issues of surgical performance, perioperative care, and then what we refer to as acts of commission or acts of omission. So how do we go forward with informed consent? We know that informed consent basically means a dialogue between the doctor and the patient, explaining all the various options to the patient, a clear analysis of the risk and benefit of each of these options. Then what are the alternative treatments available, including the option of doing nothing. And if this does not really take place, if this dialogue does not take place between your first consultation and your second consultation, and ultimately when the patient comes for surgery, then it is not informed consent. The other thing that the Montgomery concluded is individualization of risks. For example, we always say that the risk of infection after a hip replacement is 1%. But the risk of infection in someone who has high BMI or who has diabetes is more than 1%. So the risk has to be individualized. Now, if there's a fracture that you're treating and there's a risk of non-union, in a patient who smokes, the risk is much higher. So these risks have to be individualized to that particular patient, which means a good medical history, understanding of their social circumstances, their views, their psyche, and then giving them good detailed information of the risks and benefits of each of these options. It should focus on the individual patient and not just generically. The doctor has to find out what views are important. So for example, for some patients who undergo a knee replacement, they might want to squat on the ground for various reasons. And other patients, it is not that important. In some women who are of low height, a leg length inequality becomes very important. Whereas someone who is a tall person or a man, minor degrees of leg length inequality are tolerated quite well. For some people, death is a real concern. Some people will say, I'm not really bothered about death. But you have to individualize the risks and tell them the complications. Now, which complications do you mention? Anything that is frequent or anything that is serious. So death might be a very low frequency complication, but it is serious, so it has to be mentioned. Amputation after a knee replacement. I don't know how many of you mentioned it, but I've mentioned amputation as a risk of a knee replacement for the last 20 years, right from the day I came into the UK. It's a low risk, but when it happens, it's a very serious risk, and therefore it has to be mentioned. So these were the guidelines that were already in existence, and all that the Montgomery judgment did was converted them into law. Who should obtain consent? It is the surgeon who is going to operate. So if I'm going to perform a complex revision for a pelvic discontinuity, it is not sufficient that I tell the SHO to go and consent the patient because he's never seen the operation. He might, leave alone doing it. The person should be suitably trained and qualified. He should have sufficient knowledge of the proposed investigation or treatment, and he should understand the risks that are involved. So this is the 4-step model that was prepared for consent. First, you make an assessment of the patient's medical history, views, characteristics, knowledge, attitudes towards risk, and capacity to consent. That is very important, but that's not a topic of this talk. Capacity to consent is a topic in its own right. Then the doctor will use his specialist knowledge and experience to determine which investigations and treatment are likely to benefit the patient. Now, luckily in orthopedics, this is not that complex. We know that, if it's arthritis, it's either going to be doing nothing or doing an injection or doing a hip replacement, or very, 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 very rarely doing an arthrodesis or something like that. Then you explain all these options to the patient and the burden of the risks of each option and make sure that the patient has understood it. The patient that gets given time. So he goes home and he cools down, he reads your letter, he reads a little information booklet, and he takes his time to make a decision. And then he comes and tells you, okay, I think I've understood this. I'd like to have a hip replacement. Or he'll come back and tell you, look, I don't really understand this at all. Can you please explain it one more time? And then you have to give them the time. A duty of care to our patients. Has that duty been breached? Number 2, what is the causation? So has that breach of duty resulted in harm or damages? And then something called the condition and prognosis. Enough precaution to protect the sciatic nerve. The patient then wakes up with a foot drop. So a breach of duty here is in consent and in surgical performance. The causation here is the fact that the patient has a foot drop. And the condition and prognosis will be that at the end of 2 years after this breach of duty, the patient has a persistent foot drop and therefore can no longer work as a manual laborer because he has a foot drop. And that's how the courts will then calculate the compensation. But at the same time, we know that sciatic nerve injury is a recognized risk. So if you have consented the patient properly and you have taken all due precautions during surgery and the patient still wakes up with a foot drop, then that's a non-negligent complication. And then the patient is not entitled for any damages. And that is have come to litigation. The first example is an X-ray of the pelvis. And I know some of you are pelvic surgeons in the group, and we also know how difficult it is to identify a sacral fracture on a plain X-ray in casualty. So this sacral fracture got missed and it got diagnosed 2 months later because the patient had some backache. On a CT scan, by that time, the fracture had already healed. So yes, there was a breach of duty in missing the fracture, potentially, because no further investigations was done. But what was the causation? The causation is a delayed diagnosis of 2 months, but the fracture still healed beautifully. And by 6 months, the patient was completely asymptomatic. So there were no damages as such. So in this case, the condition prognosis and the causation element is quite small, and the compensation will also be fairly small. Missed slipped upper femoral epiphysis figures out very commonly. And that's why, you always educate people that if you have a child who is 12, 13, 14 years old and comes with knee pain, examine the hip. Don't miss a SUFI. Delayed diagnosis of septic arthritis is unfortunately very common. And we also know that within 48 to 72 hours, permanent joint damage will have occurred in the septic arthritis. So usually the breach of duty in this case is, was it reasonable to suspect or not suspect that there was septic arthritis? Was it reasonable to wait for 4 days before evacuating the joint of pus? And these are the questions that crop up. Delayed treatment. Common conditions are cauda equina syndrome with some bladder sensations. And we all know that if treatment is delayed in this condition, then you can potentially wake up with permanent loss of bladder and bowel function. Compartment syndrome figures out very commonly in a case of delayed diagnosis. So you've done a tibial nail today evening, then you go home, and by tomorrow morning, the patient wakes up with barn door compartment syndrome. It gets labeled as post-operative pain and gets ignored. Day after tomorrow, the patient already has established Goekman's ischemic contractures or gangrene has started. So that's a common situation. The next topic is surgical performance. And this is what you actually do during surgery. Have you taken precautions to protect the sciatic nerve? Have you done your templating during a hip replacement? Do you know what your leg lengths were before surgery and after surgery? Did you take all precautions to make sure that your joint components were positioned correctly? So these are the factors that come in surgical performance. Perioperative care. So you have done an operation, you've done a knee replacement, and the patient has a leaky wound at the end of 3 weeks. How do you deal with the leaky wound? Do you sit on it for 6 weeks, or do you go in aggressively and wash the wound out? So these are the issues of perioperative care. Sometimes you have done an uncemented hip replacement and an X-ray does not get taken. And the first X-ray which gets taken at 3 weeks shows that there's a periprosthetic fracture of the acetabulum. Was this breach of duty? So these are the topics that come in perioperative care. Trauma-related problems also come very frequently. Performance of how was the THS done? Was the reduction appropriate? Was the guide wire positioned correctly? What was the tip apex distance? And now, because these cases are common, a lot of solicitors who deal with medical negligence have become very intelligent. They actually know all these things. They know what is reduction, what is direct and indirect reduction. Many of them will know how a particular operation has to be done, how an intermediary nail has to be done. They understand what an entry point is. They understand what the reduction is. So people from the legal industry are obviously incredibly intelligent. Acts of omission or acts of commission. If you've done a hip replacement and forgotten to give antibiotics prophylactically, and the patient then gets an infection, that becomes extremely difficult to defend. The same with risks of blood clots, DVT or pulmonary embolism. We've got national guidelines now in the UK for most things. We have national guidelines for VTE prophylaxis. We have post guidelines for compartment syndromes. And if you deviate from the guidelines, you have to document why you have deviated and make sure that your reason for deviation is quite strong. Otherwise, they do become quite difficult to defend. Then not giving antibiotics in time for septic arthritis, not doing blood tests when patient comes back to you with a painful hip replacement or a knee replacement, and other similar situations. Prescription errors sometimes, insulin doses, for example. These can figure out in this group of care. Nursing care. So patient has come to the hospital with, let's say, a stroke and then falls on the ward and sustains a hip fracture. Was the nursing care appropriate? Were there rails on the bed? Was care taken to stop the patient from falling? Did the patient get a pressure sore in the hospital because of lack of nursing care? So all these issues come up very frequently in medical legal practice in orthopedics. And finally, prevention. How do you prevent being sued, basically? I think that's $1 million question, isn't it? So the principles are those very principles why we all became doctors in the first place, and why several years ago we took the Hippocratic oath. Make the care of your patient the most important goal. It's not about me or you, it's about the patient. What is important for the patient? That should be the central focus of all treatment that we administer to the patient. The discussion should be very honest and frank, and you have to give detailed explanations. I have got many friends who practice in India, and when they see me do this and they visit us and they see me consent a knee replacement, and they tell me, if I tell all this to my patient, he'll run away to somebody else. Well, yes, but if everyone does the same practice, and then the practice becomes standardized, where everyone tells the patient honestly that these are the risks. If you're going to have a knee replacement, there's a risk of infection and there's a risk of amputation. Then that problem will hopefully go away. But these are unique problems that are associated with a particular health system, and they have to be dealt with by honest and frank discussions. A quick second opinion or an MDT opinion. For example, if I do a knee replacement and at 3 weeks, the wound is leaking, I'm tempted to think, oh, it'll be fine, it'll settle down. Whereas if somebody else has done a knee replacement and the wound is leaking, then I'm tempted to say at 3 weeks, this is not going to settle down. I'm going to do a washout. So what we do in our hospital is we have a policy of very quick second opinions to avoid the bias that we have treating our own patients. And you get an independent opinion, and then a multidisciplinary team has a look at the case, and then you can reach a consensus about treatment. If there are guidelines available or evidence-based medicine or protocols, then you really need to adhere to those protocols. If the evidence is strongly in favor of giving an antibiotic before a knee replacement to prevent infection, then it is not correct that we ignore those protocols and just miss out on what is evidence-based practice. But at the same time, guidelines are just guidelines. Guidelines do not mean that it is law. If you want to deviate from the guideline, for example, if my patient is on warfarin and apixaban, and the risk of bleeding complications, if I give them heparin after a hip replacement, is higher than the risk of getting a blood clot. And if I have had this discussion with the patient that, okay, I can give you Clexin injections for 4 weeks, but you'll bleed. And if your knee bleeds, just get infected, or we can go for mechanical prophylaxis. And in this case, we can avoid it. And so long as I've discussed it with the patient, with the MDT, and documented it correctly, then of course I am allowed to deviate from the guidelines for a good clinical reason. In many complex cases nowadays, we do joint operating. So 2 surgeons come together and they operate. So if I'm doing a 5th time revision of a knee replacement or a 6th time revision of a hip pelvic discontinuity, or if some of my colleagues do scoliosis surgery, all these complex cases, we do it as 2 surgeon cases. There's no harm in that. 2 brains are often better than 1. It minimizes the chances of a surgical error. Just last week, I did a knee replacement with a colleague of mine on a patient with a BMI of 50. These are difficult knee replacements for any one surgeon to do. But with 2 surgeons, the operation becomes slicker, it becomes safer, the patient feels more reassured, and you're less likely to have any errors. Don't ignore patients' complaints. After surgery, if they come back at 4 weeks and they're in a lot of pain, don't fob them off by telling them this is all right, X-rays look fine, nothing's wrong with you. Usually patients complain because there is something wrong with them. And I think it is our duty to take that complaint seriously, investigate it, and then only discard it once we know that everything is normal and this is just post-operative pain. And finally, as doctors, we have to be humble. Humility goes a long, long way in preventing litigation. Good communication skills, establish a good rapport with your patient, make sure that your patient trusts you. A lot of times I have seen that mistakes do happen, negligence cases do come, but the patient says, oh, my doctor was very nice, he was very honest to me, he was humble, he explained everything to me. So yes, something has happened, but I don't really want to sue the doctor. I would like him to carry on with my treatment. And I think that is the true mark of humility and communication skills. And finally, we have something called the duty of candor. So if something does happen during surgery, so you're doing a difficult revision, and during taking cement out from the femur, there is a perforation of the femur or there's a fracture, and then you have to extend your stem to a long stem, or you have to put a plate or something like that. After surgery, tell your patient, look, this is what I was doing, this is what has happened, this is what I have dealt with, I'm sorry about it, but this is a complication that we had already discussed. If something goes wrong, you have to tell the patient. That is called the duty of candor. The GMC takes it very seriously. So if something happens and you don't tell your patients, and if the duty of candor is not done, the GMC will look upon the doctor very harshly. Whereas if everything was done correctly, it will take a very lenient view on what has happened. So these things are quite important. And then document the actual process. If it is not documented, it is not done. This is the single most important take-home message, I think. Every step, right from your first consultation, your clinical examination findings, the first letter that goes to the GP, the second letter, each and every risk that you have discussed, the multiple meetings. So if I have a telephone consultation with my patient, I document that as well. If I have a telephone consultation with the family of a patient with a hip fracture, I'll document that as well. So everything has to be meticulously documented. The quality of documentation is very important. Often we make a joke about how doctors' handwriting is so bad and we can't even read it. I think that is not acceptable. It is not acceptable that we scribble in the notes that even the pharmacist cannot read. We have to make legible notes that the judge can read. You have to assume that whatever you're writing is going to be read by a judge. Now, the judges make an impression about a doctor. So if your handwriting is not very good, if your documentation is not very good, the judge is going to make an impression of you as a careless person who does not care. And I have heard a judge make this comment. If this doctor cannot be even bothered to write properly, how can he be bothered to do the operation properly? So all these things are important in making an impression on the judge, if at all you get sued. So finally, patient-centered care is a legal requirement. It is an ethical requirement. It is a moral requirement for us. We have a duty of care to the patient, and it is important that we follow it. Shared decision-making is very important in consent. It is no longer sufficient to tell the doctor, like Dr. Lancelot in some of the movies that you have seen from 30, 40 years ago, that this is what you will have. No, you have to give them all the options. You have to explain the risks and benefits to the patient honestly. Stay within your comfort zone. Now, if I don't do something regularly, I should not just start doing it one-off. If I'm not doing ankle arthrodesis as part of my routine practice, I should not just do it randomly, and I should stick within my comfort zone. I do hip and knee replacements. I do pelvic and acetabular trauma. I should not be starting to do shoulder replacements. And prevention is always better than cure. Thank you.
Thank you so much, Dr. Nikhil Shah. That was a wonderful talk. I really appreciate, and so got to know so many new points. And I would like to, because Nikhil Shah has, other commitments, I would like Krishnaiah sir or any other faculty, you can ask questions. So Dr. Nikhil, can you stay till panel discussion? If
I can stay for 5-10 minutes, but then the kids will wake up, and then we have some excursions planned today. So 5-10 minutes, I'm okay.
Okay. Sir, Krishnaiah sir, you are on mute.
Okay. I think, he has summed up very well. Thank you, Dr. Shah. But the point, Kasha, is that, we give some basics about the information, because the decision is made by judges, and different judges make different opinions on the same subject. Somebody says right, somebody says wrong. So as doctors, our members in particular, we have to be aware of general principles. I mean, going into one case details, I mean, Dr. Sridhar Madabhushi would agree with me that the interpretation varies. So we're talking about general principles, and on that, I'm sure all of us agree on that. That's all I wanted to add.
Actually, I'm checking in the chat box. I could not see any questions. It was crystal clear. Yeah, please, sir.
It's an excellent analysis, and I really thank Dr. Nikhil Shah. And he made out a very, very advanced, logical, legal explanation of concept. And that's correct. Though I agree with Dr. Krishnaiah that there are different opinions on different aspects. But here it is not opinion. It is a logical explanation of what kind of a consent is supposed to be obtained, supposed to be established. So that way, the Montgomery judgment is a landmark, and I think it has to be followed by the world over. So I thank once again Dr. Nikhil Shah for wonderful presentation.
One question from Dr. Neeraj Nagpal. Would you give details of alternate indigenous therapies in consent? That's interesting.
So by indigenous therapies, I think I understand what you mean. You know how the NHS works. Many of you will have probably worked or trained in the UK. We do tend to follow an evidence-based protocol. So if your therapy is evidence-based, and has a logic to it and is practiced and or common. For example, hip arthrodesis used to be a standard treatment for hip arthritis 70, 60 years ago. But today, hip arthrodesis is not a standard treatment for hip arthritis. A hip replacement is a standard treatment. So I don't discuss hip arthrodesis for all my patients. I discuss a hip replacement, I discuss injections, I discuss conservative treatment. For knees, I will discuss an occasional arthroscopic debridement, but we also get established. So yes, I will touch upon it, but I will not explain primary amputation as a treatment for a painful knee. What I might explain is amputation as a treatment for, let's say you've had an infection and you've attempted 6 revisions to treat.
Nikhil, we have lost you.
I'm sorry, I think the internet just froze for a minute.
Yeah.
So did my answer come through, or I don't know?
Last 1 minute, we have lost you.
So basically what I was trying to say is indigenous therapies, they should.
We have lost you again.
I'm sorry, my internet is quite weak in the hotel room.
Yeah, I got that. Thank you so much.
Yeah.
So in between, if we have any questions, we'll ask Dr. Nikhil Shah in chat box. So Dr. Nikhil, if it is possible, you can answer or reply to the chat questions. So if we have any. So let us move on with, thank you so much for your time, and it was wonderful listening to you. And we'll go ahead with the next talk by Dr. Neeraj. Keeping.
Well, thank you, Dr. Srinivas. Can this screen be shared?
Oh, yes.
The previous screen seems to be on.
Yeah.
Okay, the topic which I thought was relevant for today's discussion was documentation, which is something we find that doctors in India especially just refuse to learn. We all think that we know how to document when actually none of us actually properly documents. When we do audit in different hospitals, when we go to different hospitals and actually audit the files, we find so many lacunae that I don't need a judicial officer or a consumer court to say that the doctors are negligent. I mean, that would be evident just on auditing of the medical records. So if one image can be taken from my talk for today, it is this image. You may strain a lot to do a hip replacement. This child has trained a lot to pass feces, but till the time the paperwork is done, the job is not complete. Just get this message into your heads. That is the end of the talk. We don't need to listen to anything else. When we talk about documentation, what are the things which are needed? Why document? What to document? When to document? How to document? Where to document? What not to do with the documents? Where to store? How long to store? And what documents are to be given to the patients? These are various questions which have been raised when I have delivered talks on the medical records, and I have summarized them in the first slide itself. So the first question needs to be answered. Why do we need to document? One, the courts demand it from us. Courts have said very clearly, poor records mean poor defense. No records means no defense. Already it has been told by the previous speakers that if you have not recorded something, it is assumed you have not done it. And we have umpteen examples from case laws. Then there is also the issue. 2002 Amendment of Consumer Protection Act had very clearly stated that in case of death of complainant or opposite party, the case which is filed will continue, and the estate of the doctor or the legal heirs of the doctor will have to pay the compensation if it has been awarded. Now, in case the doctor dies during this litigation and his documentation has not been good, his legal heirs do not necessarily have to be doctors. How will they pursue and how will they fight the cases? So not for yourself, not for your patients, for your children, for your wife, please document. Because if you are not documenting, you are putting them at risk. And the third thing, when you take indemnity insurance, do not only think that a representative or a medical representative has come and sold something to you and you have just given a signature. Please read the document which is provided to you from the indemnity insurance. What does it say? There is an exclusion clause that the insurer are not liable to indemnify for deliberate, conscious, or intentional disregard of the need to take reasonable steps to prevent claims. And in this particular case, what were the reasonable steps? The doctor had produced no records and he provided no records. He said, I don't have any records to the company which was supposed to defend him and pay the compensation. So the company refused to pay any compensation. So if for nothing else, just for these three reasons, remember that you need to document your procedures, you need to document your consent and everything in the medical records when you treat any patient. There is this very old Chinese proverb, faintest ink is more powerful than the strongest memory. We had this case in Hyderabad. This was Apollo, there were two Apollo hospitals and there was a crush injury left arm. And this patient had to be shifted from one Apollo to the second Apollo hospital for better care, including dialysis. But in this transfer, the patient's records were lost. And doctors gave affidavits as to what was the sequence of events, what had happened. And these affidavits were disregarded. Whatever the doctors told from their memory, this was totally disregarded by the National Consumer Dispute Redressal Commission. These are not original records. And compensation was awarded in this case. Next is the question, what after all comprises medical records? Everybody has their own interpretation. Let us see. In this particular case, NCDRC specified that documents of patient's history, clinical findings, progress notes, nurse's chart, diagnostic test results, surgical procedure notes, pre-operative and post-operative findings, consent, discharge summary, all are medical records. Besides this, some doctors are very fond of making videos of the procedure and putting them on Facebook and on other social media. Now, if you are making a video recording of the procedure, please remember it is part of the medical record. And if the patient asks for it, you can ask for charges for it to be provided. But you cannot refuse to give that to the patient party. So when you are making a video recording of a procedure, which a patient who's a consumer of yours and who's being operated by you, then under those circumstances, that video recording is not only for academic purpose, it is also part of the medical record. And patient has a full right to ask for it in case of a problem later on. There are certain other things also which are part of medical records. Your accounts records, duty roster, OT registers, CSD records. Why I'm talking of these things? There have been cases where the hospital has been sued that we were operated in this hospital and the person developed infection in the surgical site. It was an eye surgery. So the hospital produced the CSD records. These are our CSD records. These are the instruments and these are the sets which were sterilized. This is the nurse's signature or this is the attendant's signature. And all this was documented. Number two, they showed the OT register. They said we did 16 surgeries on that day. And none of the other surgeries developed an infection. So this infection in this particular patient was because of lacuna in after the patient was discharged, they did not maintain proper hygiene and probably that is the reason this infection occurred. So these also become part of the medical records. Administrative records. Why do you need staff records? Because a staff who may be present and working with you today who may have witnessed the entire thing, who may become a witness in a case which is filed against you later, may shift to another hospital. Or the patient may imply that this injection was given by this nurse, and if we have our records, we will be able to prove whether that nurse was on duty that day, whether that nurse had left prior to that, or whatever. And we now also have this Clinical Establishment Act, which clearly mentions these 15 types of registers, and the 15th category contains number of other registers which are supposed to be maintained by us by law. And if they are required to be maintained by us by law, tomorrow these may be summoned even by courts in cases of medical negligence. So please do not forget that these also today form part of your records. Next is the question, what to document? The classical example is the Kunal Saha case. All of you are aware of it. The patient died in Breach Candy Hospital, Mumbai. The patient remained in Breach Candy Hospital for around 15-16 days. But the entire judgment was against AMRI Hospital, Calcutta, where the patient was admitted only for 4 days. And the patient did not die in AMRI Hospital, Calcutta. But the problem was, when this case was decided in National Consumer Dispute Redressal Commission, the documents which were produced by Breach Candy Hospital were very damaging to the case of the complainant. There was a lot of documentation on how the patient party, the relatives, had interfered with the treatment plan. They had not allowed the doctors to do their work. They had kept insisting on particular lines of treatment. And the National Consumer Dispute Redressal Commission in this case awarded 10% as contributory negligence to be paid by Dr. Kunal Saha himself. Now this became a very important issue, and when this case went to Supreme Court for enhancement of compensation, the Breach Candy Hospital was dropped from the array of opposite parties. What am I trying to say? We all have disagreements with patients' relatives. We all lose our temper sometimes when whatever we are suggesting is not being done. But we don't document all this. But in this particular case, each and every interaction the patient had with the patient or the patient's relatives had with the nurses, with the Dr. Wadia, who was the treating person, everything was documented. Nurses wrote down, we have been advised to give 4 liters of fluid till morning, which this has not been transfused at collective request of the patient and her husband. X-ray has been ordered, this has been refused by Dr. Saha. Now, these kind of things we normally don't document, but it is an important lesson for all of us that not only what we are taking in history, consent, progress notes, we also need to document these events. Then, Indraprasth Apollo Hospital, Indu Sharma versus Apollo Hospital case, 1 crore 10 lakhs was awarded in this case. One of the main reasons was the doctors kept saying, we advise cesarean, the patient kept on refusing cesarean. And the court simply asked for one thing, show us the signed refusal of consent for cesarean by the patient. There was no refusal of consent which was got signed. This was an important lapse which resulted in this kind of a judgment. Look at this case. Now, a patient had a collapse. He had cardiac arrest. He was resuscitated. The court says operation notes does not mention the time taken to get the heartbeat back. Even ACLS protocol or whatever we use in resuscitating the patient, our focus is on resuscitation. We are not focusing on the clock to see what time the resuscitation or cardiac compressions were started and what time the intubation was done and what time that injections were given or whatever. But this is what law requires. Then is the issue how to document. Of course, the handwriting has been already discussed with by my previous speaker, and this is an important issue. We are all guilty of this, and this needs to correct itself, which of course, with new laws and electronic health records coming in, will again become a non-issue. Then any record which is not signed by the consultant, by the nurse, by the resident doctor, whoever has put in that record needs to sign it. If it is unsigned, it has no legal validity. Similarly, look at this Rishabh Sharma case. This was a premature delivery and the child developed ROP. Now, the ophthalmology people, they are supposed to examine the child around 4 weeks of gestation, and at 24 days, the ophthalmologist wrote a note, had written a note, no ROP seen. The court said, you do not require to write no ROP seen. What you require is to say that you have performed a retinal examination using indirect binocular ophthalmoscope on dilatation of pupil with scleral depression to ascertain avascular zone at periphery of retina. Writing simply that knee replacement done is not adequate. You have to describe the procedure. This is something we need to understand, and this is something which we don't normally do. So many times I do an endoscopy, and earlier I see so many reports of other doctors also normal. No description given. This is unacceptable by courts, and we need to describe whatever procedure we are doing in the documents we are preparing. Then look at this case. The anesthesiologist claimed in this particular case that retrobulbar block was given. But retrobulbar block by ophthalmologists for any ophthalmic surgery is such a routine procedure, none of them bothered to document it. This was held as negligent, accepted, everybody will realize that. But what is also mentioned in this judgment is they used short forms. Glyco was written instead of glycopyrrolate. And the courts frowned on this. Use of confusing abbreviations in medical records is deficiency of service. This is what the National Consumer Dispute Redressal Commission said in this particular case. There is another gentleman. In this particular case, the patient was being advised repeated mammograms every 2 years. And after the first mammogram, 2 years later, the mammogram showed grade 4 carcinoma, infiltrating duct carcinoma. Now, in the records, the doctor wrote TPGBB because there was very limited space. He wrote this. And when the court asked, what does this abbreviation mean? He says he told the patient to go get a breast biopsy. Now, these kind of abbreviations are meaningless, and they do not let anybody understand these, and they have no validity as a legal document. In this particular case, in the prescription, this is an important issue. Now we are not talking of inpatient records. Here, it is simply a prescription which is being challenged, and the opposite party, the court held, is clearly guilty of serious deficiency in service in not issuing a prescription for his treatment of the deceased Prakash on this particular date, and then not recording the diagnosis of Prakash's events in the second prescription. We are not talking of inpatient records. We are talking now of outpatient records, and this decision is of 2009. It is very important to understand this. Medical compensation was awarded in this case. The court said patient's history of complaints, current symptoms, vital parameters, and other clinical observations and provisional diagnosis should have been written in the prescription. Another case. In this, the court held that in the prescription, there is no diagnostic dialogue. What does a diagnostic dialogue mean? What the patient came to you with a complaint, what is the other history you have taken, what is the examination findings, and again, what is your preliminary diagnosis. So you have to have a diagnostic dialogue even in OPD consultations, prescriptions. This is also 2017. But of course, the 2017 judgment came after the Clinical Establishment Act has come into play. So this in itself is now overruled by the Clinical Establishment Act, which mandates that OPD records have to be maintained. However, if a doctor in India today is again dragged to courts for not maintaining proper OPD records, medical records, then at least one judgment is there of National Consumer Dispute Redressal Commission, which said that the hospital was not required to maintain medical records of the deceased because he was treated as an outdoor patient. This judgment arises because of the defense which was taken, the 2002 regulations of Indian Medical Council Act, Indian Medical Council Act had mentioned very clearly that medical records, indoor medical records, have to be kept for 3 years. There was no mention of outdoor medical records. And based on this argument, this judgment was given. Next comes the issue, how do you store your records? How do you maintain these records? Do you do it electronically or on paper? Now, traditional method in India was manual method involving paper and books. And these need large storage areas. It is legally more acceptable as a documentary evidence as it is difficult to tamper. But computerized medical records are neat, tidy, and can be easily stored and retrieved. There is no limitation on how much can be stored. Videotapes of endoscopic procedures, electronic fetal heart monitoring charts, continuous ECG and pulse oximetry charts, they have become important evidence in court of law, and important that when you are maintaining an electronic health record, it is an issue will arise regarding the electronic signature of the patient, which has to be taken on the consents. So I know there will be technical people who will find a solution to this, but this is a difficult issue for us in individual small and medium healthcare establishments where patients from rural, semi-urban areas come. And when you're maintaining electronic health records, this is an issue which comes. Please remember, the Indian Medical Council regulations had said efforts shall be made to computerize medical records for quick retrieval. Clinical Establishment Act says clinical establishments shall maintain and provide electronic medical records or electronic health records of every patient. It does not say inpatient or outpatient. And when you compare should and shall in law, should is like a mother's advice. I may agree, I may not agree. But shall is more statutory and is something which has to be followed like a wife's demand. So this differentiation is important. And also remember that in 2013, Ministry of Health and Family Welfare had already notified electronic health record standards for India, and this was revised in 2016. So now we may be the old guard who find it difficult to shift over to electronic medical records, but gradually over time, we need to shift, and the sooner we learn, the better it is going to be for us. Similarly, when you put down your medical records, make sure they are not contributory to what they are not conflicting. Because like in this particular patient, a missed abortion, 2 previous LSCs, DNC was done, 4 units of blood were transfused. But the doctors defended that this patient died because of air embolism. The court simply asked one thing: if the patient had died with air embolism, what was the need for 4 units of blood transfusion? So when we are writing down our records, we need to make sure that they do not, they are not conflicting. Similarly, this was a case from Chandigarh. DVT, suspected pulmonary embolism, TPA was requisitioned, and one private company was asked to supply 2 injections. The hospital record says this was started and given from 9 a.m. to 11 a.m. The court summoned the supplier, and the supplier gave evidence that he delivered the injections to opposite party at 12:30 p.m. So the court asked simple question: how did you give the injection from 9 a.m. to 11 a.m. when the injection was received by the hospital at 12:30 p.m.? Next is the issue: how long to keep medical records. This is a very, very confusing arena in India. because we have multiple laws and each law says a different thing. There is a law of limitation which says 3 years later after a cause of action, a case can be filed. The Consumer Protection Act says 2 years, and the Director General Health Services has its own requirement, and similarly, Income Tax Department has its own requirements. The PCPNDT Act has its own requirements. So, and look at this, the Indu Sharma judgment, they made a reference in the judgment that CTG records, which maintain the fetal well-being, should be stored at least for 25 years. Though they were just quoting from the textbook, Williams textbook, but the fact remains it is a part of this judgment, and tomorrow somebody may demand that you should have maintained the records for 25 years. But more important here is the discovery rule. This judgment in 2010 from Supreme Court brought in the concept of discovery rule. Earlier it was a case can be filed against a doctor up to 2 years from the cause of action. You have done a surgery in 2002, the case can be filed in 2004. But now the court said that it is 2 years from the time the patient realizes you were negligent. So you have left a mop in place. The patient does not realize the mop is in place till 9 years later. So now the patient files a case 11 years or 12 years after the cause of action. And this is condoned. Number of cases have been decided on this issue. Why this is important is when cases are filed 10 years, 11 years down the line, the indemnity insurers may have changed. The indemnity insurers are experts in denying liability. They talk of claim-based policies versus event-based policies. Claim-based policy means if you have done something during the period of the policy, but a claim has not been raised for 5 years, and 5 years later a claim has been raised by the patient, and at that time you are not taking insurance from this particular company, and you have shifted to some other company, or let us assume the doctor has died. Now, that claim will not be covered by the insurance company which had given insurance during the time the cause of action had occurred. This is a very, very important issue. It's too small a time for me to elaborate on this, but this is something all associations, all doctors should spend time on, should petition the IRDA, and we should get the law change in this regard, because this is going to create a lot of problems for all doctors later. So we had come up many years ago with this innovative thing we call, I like to call Nagpal's rule. What we say is every year you give an advertisement in 2 newspapers. One should be English, the other should be vernacular. And these newspapers should be ones which nobody actually reads. It's very important. Give an advertisement that we are going to destroy records more than 5 years old, 30 days from the date of this notice. After 30 days, do not still destroy the records. Now, if you have a case filed against you 11 years later, you have that notice which you had given and you have your medical records. Take both of them to a medical legal expert or to your advocate and give him both the things. If your medical records are good, he will use the medical records to defend you. If your medical records are like 99% of the records that doctors maintain in India, then under those circumstances, he will defend you on the basis of that advertisement, that we gave an advertisement that we are going to destroy the medical records and nobody approached us for this, hence we destroyed. Next is the question, when to document. There is something called contemporaneous medical records. If you are documenting something as the events occur, this is what is contemporaneous medical records. I have given 2 judgments which have upheld this, and we are supposed to maintain contemporaneous medical records. This is important to understand But it is important for judiciary also to understand that at times when we are busy in a medical emergency, it is not possible for us to give one cardiac compression and go and write cardiac compression given and then come back and give the second cardiac compression. There will be a time when documentation is not our focus, and we will be focusing on saving the patients, unfortunately, and whatever the medical records are going to be prepared, they are going to be prepared after we are free from all this. So if this is not corrected, the focus of juniors at least will be more on the documentation rather than on the patient. And this is something which is not good for medical profession as well as for society. Look at this particular case. During ERCP, the patient arrested. It was revived, but there were no records of the patient's vital signs which were during the ERCP procedure. And ERCP procedure requires both my hands and feet when I'm doing this procedure, because there are multiple knobs and there are foot pedals and so many things which are being done. Number two, the type of health we have, all hospitals, all small and medium healthcare establishments do not have the quality second line which will do the medical documentation while the patient procedure is ongoing. But the court wanted this, and they said that you are required to carefully document the process virtually on a minute-to-minute basis. None of us do it, but none of the organizations or associations deemed it fit to challenge this judgment. What does this judgment say? Anesthetists are allowed to read books during surgery. They put on headphones and listen to music. These are all statements which are on record and obviously create an impression in mind of public as well as lower judiciary that doctors obviously are grossly negligent. In this particular case, the issue was that there is clear lacunae that there is no recording maintained between 3:30 and 3:50 p.m. This is the time when the resuscitation process was on. What was more important, to resuscitate the patient or to maintain records of the resuscitation? This is something the judiciary has to answer. This is another similar case. Post-hemorrhoidectomy, it was taken for an examination under anesthesia. Patient had arrest, revived. But the court wants, you have not mentioned the time at which the patient developed cardiorespiratory arrest, what time the same was noticed, by whom it was noticed, and how much time of CPR was required to resuscitate the heart, and when the patient finally revived. Now, this was awarded in this particular case, around 57 lakhs was awarded, and this is not a small amount.
Sir, Neeraj sir, we are running out of time.
Oh my God. So we can end over here because this can just carry on and on. In case of a medical accident, please photocopy the records immediately because a mob or the police may take away your records. What not to do with records, do not tamper the records because that tampering can create more problems for you. And remember, the judiciary is much more expert in deciding on tampering rather than deciding on the medical negligence issues. So they will pick up any tampering which you do, which you think you have done very intelligently, but it will obviously be picked up in no time. Similarly, remember that tampering of medical records or tampering of evidence is a criminal offense. In this particular case, Rahul Mahajan and the secretary of Pramod Mahajan, they were brought to Apollo hospitals in unconscious state after having taken heroin and some other drugs. And there was a pressure from BJP that please do not make a medical legal case. The medical superintendent and the doctors treating did not make a medical legal case. 3 hours later, the secretary died. Then they were forced to call the police and the medical legal case was made. And the court said there is clear evidence of tampering. There will be 2 FIRs which will be lodged, one against Rahul Mahajan because under the NDPS Act, and second against doctors of Apollo Hospital. because they have tampered with evidence. What medical records are to be given, I think all of us are aware of this, but this judgment from Lucknow High Court says something which I would like to read out. All hospitals shall maintain their records of each and every patient on their website, starting from registration of patient to the date of discharge. I'm not aware of any hospital in the country which is following this, but this is a public judgment and nobody has bothered to challenge this. And if you do not provide within 72 hours, this is negligence per se. You have to maintain confidentiality of records. Thank you so very much. Sorry, I have exceeded my time.
Thank you so much, sir. That was wonderful talk, and it is really enlightening for all the practicing orthopedic surgeons, not only orthopedic surgeons, for each and every doctor. And now we'll go. I would like you to stay for the panel discussion, sir, which is going to be after 2 talks. The next talk is by Professor Madabhushi Sridhar Acharyulu garu about medical negligence and civil aspect. Sir, can you share your screen?
Yeah. Thank you, Doctor.
Thank you, sir.
I deem it a privilege to be associated with you, to share my ideas on the subject. It was really a very educating program, and I'm benefited more than I do not know whether you will be benefited by my talk.
Sir,
I will be
one
talking
request,
to.
can you enlarge the screen, sir? Presentation, you have to keep it in presentation mode so that.
I
yes.
understand. Is it okay? Or should I do further?
It's still not there. At the same button which you have clicked in the lower corner only. Yeah. That.
Okay.
Yes. Yes.
Fine.
I
think it's clear.
Yeah.
So, though the topic given to me is medical negligence, which is being dealt by all experts who are both doctors and lawyers, like Dr. Krishnaiah, Dr. Neeraj, and then, of course, that doctor from UK. He made a wonderful presentation about the issue. I would like to focus on the aspect of prevention of medical negligence, how it can be prevented, and if it happens, how is that it can be confronted with the practice of transparency. Some of my aspects are already covered in principle by Dr. Neeraj Nagpal, and of course, with reference to the, just a minute, the presentation by Nikhil Shah also has touched upon
the volume, sir.
Very excellently. Volume?
Yes, please increase your volume.
How do I do it? Then I have to exit state.
No, sir. You be in the same presentation mode and talk close to your mic.
Okay.
Yeah. Same. Come
then
back.
I think I have to remove this. Okay. Am I audible now?
Yeah.
Yeah. This is the problem, perhaps, with the.
That's better.
microphone.
That's better.
Yeah.
Just a minute. Okay. What I am trying to tell you is there are 2 aspects of the prevention of medical accidents, whether it is caused by negligence or any other aspect. Record keeping, as Dr. Neeraj has rightly pointed out, is a very, very important component of entire exercise. Generally people say that we will be overburdened. That is the talk, even from government offices. When I was commissioner, I was facing this kind of question. Yeah, it is definitely a burden, additional burden. But I would like to give the example of police. The police have to do the most difficult, complex investigation, and they have to keep everything documented every day, every minute, every hour, perhaps. And they have to submit that record for the scrutiny of the judiciary. Now, that is a more burdensome practice that is essential for establishing justice. So when police could do that, I think every professional, other professional who is having the risk of litigation and question of liability to be decided based on the documents, I think it is very, very important for the doctors to maintain the record and of course share with relevant people, including the patients. And my focus is on how is that your transparency prevents you from making yourself liable, and how many times it can save you from liability is the question. At the same time, if there is a real negligence based on honest disclosure of honestly maintained documents, the liability also can be fixed, and it can also prevent the false cases or presumptions or inferences or various other kinds of impressions that might cause a judge to think that a doctor is liable. So to prevent or establish, to escape or establish a liability, maintenance of records and sharing of records is very, very important. That's the aspect I am trying to deal with. Based on my experience as an information commissioner with reference to medical records, I'd like to focus on the need, which has already been highlighted by Dr. Neeraj Nagpal. Now, there was one case, very interesting case in my experience. One officer of a very highly credentialed department of a union government came before me. The problem was she was complaining against the corruption around, and she was a very young, enthusiastic, enterprising officer. But she was not tolerating corruption of colleagues and bosses. So she went on complaining against them, and they felt it is very, very embarrassing and suffocating. So they made a complaint against her, saying that she is not mentally all right. Then she was sent to Institution of Behavioral Sciences in Delhi. There she was examined, and then she was detained for one month. Nobody knows why she was detained. Then she wanted to know what was the reason for her detention for 1 month, and if at all they have found anything very serious with her health or any other problem. Just a minute, I'll switch on one minute. So if there is anything serious with her health, she's also expected to know. Then she filed an information request for the record. It was denied by the PIO. It went up to first appeal, and the officers, the doctors have denied it. Then the case came in second appeal to me as Central Information Commissioner. I'm supposed to deal with that. Then the director of the institute came, and he represented that this is a very, very problematic case, and it is difficult to reveal because it will expose so many other major personalities. Then they denied to give the information. And I was examining the duty of the doctors, the duty of the hospital to disclose the information according to law. Under the Right to Information Act, there is one definition of information which says, if information from public and private hospitals is accessible through another legislation, and if that legislation provides a mechanism to retrieve that information, you must get that information through Right to Information Act. You can. And the Information Commission is entitled or authorized to explore the mechanism of disclosing that information. So that was before me. And then I was trying to refer to Medical Council Act. And then the Medical Council Act has certain rules in which the doctor has already said, if it is demanded, the information has to be delivered to the patient within 72 hours. The rules prescribe that. That means there is a law for every doctor, whether it is government doctor or public doctor, he has a duty to share that information with the patient. I'm not talking about third parties information. If somebody else is asking information about your disease, it becomes confidential. It becomes private. Your disease is your own. Your disease-related information is your own. Your treatment is your own information. Can that private information be shared by others is a different question. I'll deal with it at the last part of my presentation. So basically, a patient whose body is explored by the doctors or diagnostic experts to know what the disease she's suffering from, I think it is the duty of the doctors to share that information with the patient. And it is a well-established right. It is generally saying right to health is regarded as an important component of right to life under Article 21 of Indian Constitution. Right to life can be deprived. Right to life can be deprived only through established procedure of law, not by any other means. Then if right to life includes right to health, can that person be deprived of his health? Means the only exception available is yes, only through established procedure of law. I don't find any established procedure of law to deny the health and deny the health related information. Then second important constitutional right a person has in our constitution is Article 19(1)(a), the right to freedom of speech and expression. Just now we have discussed how the informed consent and involved consent is very important in decision making, either by the patient or by the doctor. So then what does it mean? How do I give consent to you? If I'm a patient, how do I give consent to you? Giving consent means I'm taking a decision to be treated by you. So if I have to take the decision and express my opinion that I will be taking your treatment, I must be informed. So internationally, it is accepted that the right to freedom of speech and expression includes right to information. I just give the profession example to you to say that we have right to elect a representative, political representative. Then don't we have right to know their criminal background, property background, education background? This has come up for the discussion because of a litigation filed by Trilochan Shastri, a professor. And the question was well taken by the judiciary, and judiciary in 2002 decided that every voter is entitled to know the criminal background, whether it is personal or official, or whether his economic background, personal or official, his educational background, whether you treat it as personal or official. He's entitled to know that. And then he has to take a decision whether we have to vote this fellow or that fellow, knowing that this is the criminal background, that is the criminal background. If they elect him in spite of criminal background, we can't help. It is unfortunately, it's our democracy. So, you know, even in present ministry, you find 24 legislators, 24 ministers having serious criminal record. That's, of course, our terrible system. Okay, apart from that, what I am trying to tell you is, even if I vote a criminal to the office, political office, I must know that he is criminal. So the information is an important part. So here in this case, I have discussed the various components of right of a patient to know the health information, treatment information, diagnostic information, day-to-day maintained, hour-to-hour maintained, as Dr. Neeraj Nagpal has just explained. Then the judgment was given. It was taken to the Ministry of Health and Ministry of Health in the central government through Law Minister. Law Secretary at the time was Mr. Malhotra. He found my judgment and he forwarded it to the Principal Secretary Health and said that please share this judgment with every health secretary of every state in the country and see that this right to medical records of a patient be implemented. What was discussed till now by Dr. Neeraj and others is the right of courts to receive the medical records. But more importantly, it is the right of the patient to receive the records, because he can also understand whether there is any problem with the treatment given to him or not. We believe in good governance practices, and one of the good point in good governance is transparency. If you are transparent enough, your honesty, if reflected in your records, you can never be made liable for what you have done, unless there is a serious negligence committed by you. So the transparency is a mechanism to prevent undue litigation. It will also make the patient understand what are the efforts taken and the toil that a doctor has resorted to or involved with to save the patient and to reduce the pain of the patient. So right of patients to medical records is an unquestionable right, and it has to be complied with. And I have one difference with medical council rules. They say only if it is demanded, it has to be given within 72 hours. In my view, I quote the example given by Dr. Neeraj, some Gujarat court given a judgment, it should be on the website. I do not know whether it should be on the website or not, but I feel every patient at the end of his treatment when he is being discharged, whatever capacity, whatever status he is, he should be given a set of records, honestly certified record of a medical treatment, including the diagnostic reports to him, because it is his body, it is his risk, it is his money, it is his consent that he joined you for your treatment. He is entitled to. His record is his property, not your property. It is not property of hospitals. It is not property of the doctors. The information regarding the patient is property of the patient. And he deserves logically, legally, sociologically, and even from the point of view of your medical problem, practical medical problem. Just now I heard the introductory speech where the doctor from Warangal was speaking. He was trying to prove that it was raining. I appreciate his enthusiasm to prove that it is raining. And similarly, you have to prove everything that you have done. That is the duty of every person who is dealing with the public activities. So he was telling how do we prevent litigation? My answer to this question, one important answer to this question is be transparent, maintain honest records, share them with the patient. I think it will definitely reduce the liability to a great extent. If not, there is every possibility of adverse inferences being drawn. This is the first point I would like to make. I hope you know that this is wonderful statement of our Vedic text. Sharire jarjari bhute vyadigraste kalebare aushadam jahnavi toyam vaidyo narayano harihi. Vaidyo narayano harihi is extracted from this shloka and given different interpretations. It's not correct. When the body is subject to decay due to old age and all sorts of ailments attack, the only medicine is the holy waters of Ganga, and the doctor is considered as Lord Krishna, Hari, and Narayana. So this is a very pious statement, and there are great doctors, and I really admire them. And in fact, even in these COVID days, they are the frontline warriors. They are equivalent to the captains and commanders that they are fighting on the borders of the nation, and they are trying to prevent the enemy called COVID virus. And really, they have done a wonderful job, and my tributes to them. These are the source material of what I'm making a presentation today. I am going to share I have already shared this with your doctor, and you can also have and go into these documents and understand the points I am trying to make today. Then right to health, I have already discussed this. Right to know reasons for the huge charges. This is a very important thing. Dr. Krishnaiah has already pointed out, we are no more a profession, we are a business, we are an industry, we are a commerce. And there's no point in claiming the divine aspects to the treatment that you are giving. Even if it is a free treatment, I think the duty lies, various kinds of duties lies. And if you are charging, I think it is the duty of the doctors, not doctors, duty of the hospitals. It is the right of the patients to know the reasons for the cost, profit margin, and what is the rationale. If you are imposing so much of cost on me and I am supposed to pay, selling my property to come out with no dues, I think it is my duty, right? And it is your ethical duty and legal obligation. Okay. Now we have to look at the issue from the point of view of the rights of the patients, as Dr. Nikhil has rightly pointed out. The patient's requirement, patient's necessity, patient's pain, patient's disease, and patient's rights are absolutely important, and it cannot be ignored. And the duty of a doctor comes from the right of the patient. I'd like to say technically in law, my right exists only when your duty exists. If you don't have a duty, I have no right. So right of a patient, a right of a person depends on the legal duty of the other corresponding personality. And they are inseparable couple. It cannot go without corresponding reciprocal duties and obligations. So that is a legal requirement. Here I'm putting one case where unduly a patient was charged 15.6 lakh for various things, and doctor wanted to explain the cost. They did not explain it. It was ultimately proved to be overcharging, and he was made to pay the damages. Then if survived, the doctor, this is a lighter vein thing. Consumer Protection Act has been rightly pointed out and discussed by the various other speakers, so I do not go into that aspect. I'd like to say one thing here, because I'm, according to the schedule of your distribution of topics, I'm supposed to talk about the civil liability of the doctor for negligence. Let me tell you, sir, civil liability of the doctors do not depend especially or necessarily on contract. Even if there is no contract, even if there is no consent form, even if there is consent form, the liability of the doctor depends on the situation. The situation means the sudden emergence of relationship between a doctor and patient that happens when somebody brought unconscious to the hospital, and you are supposed to render your responsibility. And there are judgments in the Supreme Court that say you cannot reject a patient to be treated by another hospital, number one. You cannot also reject patient because you don't have consent form signed, or so many other things. your primary duty is to treat the patient because of your position in the society, because of your education qualification, and the duties that you have taken upon, the promises that you have made. You are supposed to be at the forefront to treat the patient without or in spite of any written document. So this is called law of torts. In law of torts, liability arises out of breach of duty. And breach of duty means breach of duty to be careful to the patient. And the right of patient arises out of this situation, whether there is a contract or not. That's a very important thing. And the second point is intention. What is the role of intention? When you discuss criminal negligence, my friend Dr. Damodar will be explaining you. The difference, main difference between criminal negligence and civil tort is civil liability is more stricter than criminal liability. In criminal negligence, you can escape by telling that I don't have intention to kill this person. I have acted in good faith. So you have so many defenses available. But whereas in civil liability, your intention, absence of intention is immaterial. We do not go into that question at all. Whether there is a negligence or not, that is established. If that is established, the doctor will be liable in spite of his good intention, good faith, and very hard work that he has undertaken. So that is the difference between civil liability and criminal liability. And civil liability is stricter. And it is, I'd like to explain you the expression strict liability. Strict liability is that liability which gets imposed in spite of intention or without intention. So, but intention is a relevant factor. Suppose it was deliberately, if it is so reckless that it is on par with deliberate inflicting of injury, he will become liable criminally, and he will become liable exorbitantly in civil liability. There will be exorbitant amount of damages that will be imposed upon. That is the final point of civil liability I would like to explain. Then Dr. Neeraj and other doctors have explained Bolam test. Yeah, how it is transformed into Montgomery judgment. It's a fantastic analysis, sir. I request all the doctors to go through that judgment and simply follow that. That is one thing. And then I have already discussed Medical Council Act 1956 in that case, where the liability to share the records arises out of this rule. Then these are certain cases, Raghunath Ji Raheja, where it was held that the necessary collectors are supposed can claim any secrecy or any confidentiality in the matter of copies of the case papers relating to the patient. These must be made available to him on demand, subject to payment of usual charges. If necessary, the medical council may issue a press note. That was the suggestion. Then Kerala High Court confirmed it. Gujarat High Court also said the doctor can be held guilty of deficiency in service if case records were not produced. This point was well established and emphasized by Dr. Neeraj. Ashok Qureshi also is another case where you are expected to retain the medical records until the complaint is disposed of. All your limitation clauses or those clauses will not apply the moment the case is lodged. You are supposed to keep up the information. Even in the Right to Information Act, though destruction of records is permitted, Public Records Act also is there. There also it is permitted to destroy, but once the dispute arises, you are not supposed to destroy. You have to keep it up until the dispute is finally resolved. Then in this Shyam Kumar case, there is a judgment which says of National Commission that says not producing medical records to the patient prevents the complainant from seeking an expert opinion, and it is the duty of the person in possession of the medical records to produce it in the court of law, or adverse inference could be drawn for not producing the records. What is adverse inference? Inference means what? Presumption. There is no proof, but I presume that you are negligent. And I think presumption is more dangerous than the real proof. Instead of suffering the adverse inference, doctor is expected to produce the real documents, which will be of great help to fixing the liability or escaping from the liability or fixing exact amount of money to be paid to the patient. Dr. Neeraj was talking about contributory negligence. That means if patient is also negligent, that to that extent, the damages will be reduced. So for that also, the record will be of great help. These are some more cases where if the record is, case sheet is not maintained properly, it will be considered as negligence. Then in Shanta case, VP Shanta, I think you know these cases very well. It was held that failure to deliver X-ray films is deficiency in service. And it's an issue. Similarly, Devendra Kantilal case, it disbelieved the evidence of the surgeon because only photocopies were produced. You must have originals with you. Or in alternative, the electronic record. Then in this case, it was the hospital was found guilty on the ground that the name of the anesthetist was not mentioned on the operation notes, though anesthesia was administered by 2 anesthetists. But these are certain aspects. And UK, I need not deal with UK law because doctor has already explained. I was telling you the 2F of RTI Act, and this is the case I explained you, NP Bhatia versus institution. And these are some other cases where the records are supposed to be maintained. The question is whether a spouse can seek medical information of the other spouse. Now, the privacy, privacy is one of the latest invention of the judicial precedent, that it is part of fundamental rights, and every individual is separate, whether even if it is spouse. So unless there is a public interest in disclosure of the information, you need not disclose. That is, of course, under Right to Information Act. But let me tell you, there is a another very important case. Let me deal with that. That is Mr. X versus Messrs. Z Hospital. In this, what happened? A patient was suspected to be HIV patient in a northeastern area. He was taken to Chennai. At the time, there was no diagnostic services available in northeastern states. The patient was taken along with a young doctor to Chennai. And when Chennai doctors tested the patient and the attending doctor also, it was so proved that patient was not having HIV, but the attendant doctor was having HIV positive. It's a very interesting case. Then he's a young man of 25 or 26-year-old man. His engagement was already fixed, and his fiancée doesn't know that this lover is having HIV positive. Then somebody, after going back to northeastern state, it was discussed that this doctor was suspected to be HIV positive. Then the fiancé is supposed to marry that person, has called on the doctor in Chennai hospital, and wanted to know confirmation whether this fellow was HIV positive. Then doctor is in doctor's dilemma, whether to disclose or not. Then he ultimately decided right to life is more important than right to privacy. And he thought it is in public interest that I should disclose. And he disclosed that this person, this young man is suffering from so-and-so, so-and-so. Then she dropped the marital contract. The engagement was cancelled and she did not marry him. Then this man approached the Supreme Court saying that I have a right to marry. But because of doctor's disclosure, he could not marry. This was his contention, but the court said, your right to marriage depends on the consent of the other partner. And the consent of the other partner is supposed to be informed consent. See, even when you are joining a public employment or a private enterprise, they conduct your complete medical test, whether you are a fit person or not. But when you are supposed to marry, why don't you give entire medical information to your spouse? Where is the personal information here? So that was the decision of the Supreme Court, that informed consent, even in the marital contract, is a very, very important component. And if you are suffering from any disease, you are supposed to disclose it. Then, because Section 13 of Hindu Marriage Act provides the disease, mental or physical, as a ground for divorce. That is another reason you are supposed to give. And there is one more very interesting case, a political case, where one minister was condemned for contempt of court because he defied the judgment of Supreme Court in not allowing the cutting of forest for timber in a particular area. Then he was convicted for 1 month. He is supposed to be there in the jail for that minister of Maharashtra. He is minister of Maharashtra. He is supposed to be in jail for 1 month. He went to jail and he saw the jail that are maintained in Maharashtra government, and he realized how worst they are. And he held his chest and fell down as if he is suffering from some kind of a heart disease or something. And he was admitted in one of the fine 5-star hospitals of Bombay. He was treated for 29 days. And on 30th day, he was released from the hospital as if he is released from the custody. It's a fraud on the Supreme Court by this person, by this former minister. He wanted to escape the harshness of the prison by showing false pretext of disease. Then somebody wanted to know what exactly the disease of Surup Singh Kriya Naik Then it was denied by the hospital, denied by the government. Then he came to Information Commission, denied there also. Then he went to High Court, and High Court of Bombay said, in public interest, even if disease-related information is private information, it has to be released because the government has spent money on that. Similarly, there is another case which I decided in my career. Prabhat Kumar's father was admitted, and he was his father died because of negligence that is suspected to be. Then he wanted to record information that was demanded and given. Thank you. So at the same time, there are issues of confidentiality, and you are supposed to maintain that. And this I have already discussed. It was a ground of divorce not only in Hindu Marriage Act, Special Marriage Act, and the Indian Penal Code also prescribed in section 269 and 270 about the crime of possibility of negligent spreading of a disease, which will make him liable. This is another case where I said in Delhi there are 20 hospitals, and I do not know whether you are aware that the dishonest treatment and dishonest exploitation of patients is very rampant in northern states, especially in Haryana, Punjab, Delhi, and those parts of Uttar Pradesh. Not so rampant in South India. That's what I noticed. So there is a need for a perfect development of law in prevention, possible prevention of dishonesty in treatment, which might result in finally result in liability for medical negligence, either in civil or in criminal cases. So there I said the transparency will be one of the methods of preventing this litigation. And there are 20 hospitals, though they are private hospitals, because they are on the concession rate. They got land on concession rate. They are treated as public authorities according to Right to Information Act, and they are liable to share the information. So it is the duty of and even these two cases, Muslim marriage law and Parsi marriage law also imposes a condition that the diseases will be the disqualifications or demerits for the marriage, and you are supposed to exchange the information. What I'd like to conclude at the end of this presentation is the patients have right to information about their medical treatment, and there should be an automatic mechanism in all public and private hospitals, and even in small nursing homes or individual doctors. They are supposed to maintain the documents and hand over the entire set of the documents to the patient or his legal representative authorized by the patient, so that the transparency helps the doctors, patients, and the systems, criminal justice system and justice system to take correct decisions. Thank you very much for your kind opportunity, and I'm really educated in this seminar.
Thank you so much, sir. That was really an excellent talk, and got to know so many things. Can you stop sharing, sir?
I already shared. I'll stop sharing. Yeah.
It is on the top part of the screen, sir. Yeah. Thank you so much. So I would like you to be here for the panel discussion, sir. We'll go ahead with next talk.
Right.
By Sri Damodar Garu. He is a retired IPS officer, retired IG. Sir, he is going to talk on medical negligence, the criminal aspects. Damodar Garu, over to you, sir.
Yes, sir.
Yeah. Can you start sharing?
I'm sharing the screen.
Yeah.
Yeah. Good afternoon, distinguished speakers and participants. I'm not going to smother you with too many legal citations or too much of law. The thrust or the purpose of my interaction with you is limited to assuring the doctor that you need not be alarmed by the looming threats of litigation on the medical profession, and also the recent incidents of violence and assaults on the doctor, what the law safeguards for you. The intention is, if a driver knows the traffic rules, automatically he follows. And if a truant policeman catches him and tries to exploit him, he will be confidently able to confront him. That is the idea with which I am trying to talk to you in general terms to talk to you about it. Now, This law on medical negligence, legally called malpractices in the Western countries, is very well developed. But unfortunately, in our country, it is still nascent. It is still evolving. Hence, there is a need for lack of clarity and lack of comprehension about it. And in this regard, this particular initiative by you, by the Telangana Orthopaedic Association, goes a long way in promoting the legal awareness on the subject, which is very badly needed. Now, in the United States, very well aware that you are all aware by 1995, in the case of Mrs. Rajeshwari Ayyappan, everybody became aware of the medical liability. Mrs. Rajeshwari Ayyappan was the mother of actress Sridevi. And a Manhattan hospital, the neurosurgeon there operated her on the wrong side, taking inadvertently, carelessly, and negligently the X-ray record of some other patient. And the consequences, all of you are well aware, and I don't want to repeat. But unfortunately, in our country, unlike the Western society, like the United Kingdom or the United States of America, we don't have any codified law nor any central legislation on the lines of PNSDT Act, which is Prevention of Neonatal Sexual Determination Tests Act. Hence, the law as it is applicable is from the age-old Indian Penal Code and also several decisions of the constitutional courts, that is the court, Supreme Court and the High Courts. The speakers prior to me have elaborately mentioned various items available on the subject, but I will only tell you only 3 matters because those citations, etc., are useful if you are presenting your case either for a prosecution or a defense in a judicial forum. But as a generalist doctor, your core aspect is practice, and to be confident against litigation, etc., as a shield, I'll give you only 3 aspects. The first and foremost is the decision in Joseph Matthew case, which is relatively comprehensive. The other citations, the distinguished speakers prior to me have presented, go into the minutest details, but I go at a macro level broadly. Similarly, in the fag end of my presentation, I would like to give you a couple of slides on the recent issues of violence and associates and what are the legal safeguards available to the medical professions. Now, what is negligence? They have already mentioned. It is for every professional, be it a legal or chartered accountant or a healthcare professional. The defendant owes a duty of care to the plaintiff, and the defendant has breached his duty of care, and the plaintiff has suffered an injury due to this breach. And medical negligence is where the negligence is caused by a medical practitioner. It is as simple as that. This negligence is predominantly medical, is the theory of liability, mostly, and concerning allegations of malpractices, and it falls mostly within the purview of the law of tort, that is seeking damages for wrongdoing. But when medical negligence, what is medical negligence all about, was clearly laid down by Supreme Court in a decision, which citation I have mentioned here. When a doctor is consulted by a patient, the doctor owes to his patient certain duties. This is stipulated by the apex court of our country. Hence, it carries the weight of an enactment of the parliament. When he is consulted, he has 3 duties devolving upon him. They are duty of care in deciding whether to undertake the case or not. B, duty of care in deciding whether what treatment to give. Then duty of care in administering the treatment. That is to accept the case, to decide the treatment, and to administer the treatment. In any of these 3 duties, if there is any breach, then the cause of action for negligence, etc., will come. Based on that, the doctor can be proceeded against. But essentially, the medical negligence falls within the domain of civil liability, civil in nature, but sometimes it becomes criminal, and that is what I am going to delve deep now. What is medical negligence? Dr. Krishnaiah has quoted Lord Donaldson. Please be assured that the doctor's duty is not to cure the patient, but to provide care. You are not called upon to cure. When a patient comes for therapy, you provide reasonable care. That's all. There is no assurance of cure. So, death of a patient during treatment is not medical negligence per se. If anybody dies, you don't have to be worried. that it is negligence due to negligence. Similarly, what is not medical negligence? Fraudulent activities by healthcare professionals do not come under the purview of medical negligence. For example, in my service of 30 plus decades in Indian police service, I have come across a case of a ambulance driver being in collusion with a broker and not taking an accident patient to the nearest hospital, but taking to the far off hospital where he gets extra commission or kickbacks. And in the process, due to delay, that golden hour concept, etc., the patient dead. It was proved. So it does not come under medical negligence. It's fraud, outright fraud. Similarly, organ transplantation. I don't want to mention the name of the hospital. It happened in Visakhapatnam, where in the organ transplantation, though treatment per se was good, the procedures laid down as per the act preceding to accepting a patient, preceding to accepting the donation organ were not complied with. So the hospital and others involved were prosecuted. That doesn't fall under medical negligence, right? Next. Now, as Dr. Madabhushi Sridhar has covered, and as I have reiterated in my previous slide, it is essentially a civil liability, and Supreme Court has decided that the medical profession comes within the ambit of Consumer Protection Act. I was administering this Consumer Protection Act in my last assignment as IG of Legal Metrology, where taking care of the consumers was my primary duty. So in this decision, all hospitals became aware of the fact that as long as they have a patient, all patients are consumers. Please mark, even if the treatment is given free of charge. This is the core aspect of this Supreme Court decision. That patients come under Consumers Act is well known. But what is being generally glossed over is that even if a treatment is given free of charge, say in a government hospital, etc., it is liable for damage. This is what this cited Supreme Court decision says. So just because you have treated him gratis, that doesn't mean that you escape the liability in case of lack of reasonable standard of care. When becomes criminal? As I told you, that it is essentially civil in nature. You can only be sued for damages. But when it becomes criminal, the National Commission has laid down that when proper treatment is given, the death occurring due to process of disease and its complication cannot be held that the doctors and the hospitals are negligent. As I told you, somebody is writing on it. Anyway, as I told you, that doctor's duty on the doctor is, the duty cast upon the doctor is for care, not for cure. Hence, if somebody dies, he cannot be held responsible as negligent. But the principle regarding medical negligence can be very clear. He can be held guilty of medical negligence only, please remember, when he falls short of the standard of reasonable Medicare. When he falls short of the standard of reasonable Medicare, only then the criminal liability arises in respect of that practitioner or the hospital affording health care. Now, I'll come back to this historic decision of Jacob Matthew versus State of Punjab. It is a well-rounded decision. It looks at both the patients and also the caregivers. There are some safeguards here. So I would expect each one of you to go through this judgment, commit it to your memory. Short while ago, a speaker has mentioned that the Chinese proverb that a faintest ink is better than memory. But here, in this case, the Jacob Matthew case, you have to go through, and the salient aspects, please commit your memory, because it works as a karna kavacha to afford an element of confidence for you while treating any patient. It is a landmark judgment. It clearly says when a doctor can be held criminal on account of professional negligence or deficiency of service. It arose at Chandigarh by a doctor of CMC. It says doctors should not be dragged to criminal courts as a matter of routine. The first postulate laid down in this judgment is. The next is to prosecute the medical professionals for negligence under criminal law, something more than mere negligence, something higher than mere negligence had to be proved. So please remember, something more than mere negligence had to be proved. The decision of the apex court says. So I'll just read out the relevant excerpt from this case. Sometimes the decision may not be correct. That would not mean the medical profession is guilty of criminal negligence. This helps you. This comes to your rescue. Such a medical professional may be liable to pay damages of negligence. Unless the negligence is of a very high order, the medical professional should not be dragged to criminal proceedings. This is the Bible coming to your rescue. It's the Karna Kaucha. That is the reason why in Jacob Matthew's case, this court has held that in case of criminal negligence, medical professional, it must be shown that the accused did something or failed to do something under the given facts and circumstances of the case, which no medical professional in his ordinary senses and prudence would have done or failed to do. Ordinary prudence would have done or failed to do. This is important. So it's a very subtle distinction, but it's a very significant utility to you to shield yourself against any threat of criminal proceedings being launched against you, because the threat is always looming large by unscrupulous peoples. Now, what are the safeguards? A private complaint cannot be just like that. Private criminal complaint, I mean, cannot be just like that lodged against a medical professional unless the complainant is able to produce prima facie evidence in the form of a credible opinion given by a competent doctor, to support the charges of rashness or negligence on the accused doctor. So just like that, you can't go and lodge a private complaint in criminal proceedings. But nowadays, what happens is, being unaware of it, or even being aware of it, the unscrupulous litigants go to the police station, drag something, scribble a few lines on a piece of paper, and on this ABCD healthcare hospital or ABCD doctor, etc., they are coming and troubling you and robbing you of peace of mind. It's not correct. So that is the reason why I tell you to commit to your memory the safeguards provided in this case by the Supreme Court. And as you know, till an act is enacted by the Parliament, the dicta of Supreme Court carry the weightage or force of a duly enacted law of a Parliament. Hence, you have to rely upon it. Now, case is lodged, a competent authority verifies that there is criminal negligence. Case comes to you, or somebody comes to you. I go to a police station, or somebody comes to me as a police officer. I cannot, before proceeding against the doctor for negligent or etc., I should go and obtain an independent, competent medical opinion, preferably from a doctor in government service, qualified in that branch of medicine. Supposing I go on to a director of medical education on a complaint against orthopedic surgeon, and if that person is a general physician, of what he may be in a position of authority. So he should have that knowledge, domain knowledge, and that doctor should be able to give an impartial and unbiased opinion, applying a prescribed test based on the facts collected in the probe. The prescribed test in our country is still Boehm's test, even though Dr. Nikhil Shah has mentioned it is superseded by the Montgomery judgment in the British courts. But Montgomery judgment, as said, is not adopted in our country. Boehm's test, I understand, and I am subject to correction by legal humanists like Dr. Madabhushi, Sridhar, Acharyulu, whether Montgomery test can also be applied in supersession of the Boehm's test, whatever it is, some standard test, whether it is Boehm's or Blithos, as Nikhil Shah has mentioned, or Montgomery judgment, some test has to be mentioned. So he cannot proceed just like that. Now, arrest. It is the draconian threat looming large always against the doctors and the managements of the hospitals. You cannot arrest unless arrest is necessary for furthering the investigation or for collecting evidence, unless the investigation officer feels satisfied that the doctor proceeded against does not make himself available to face the prosecution. Unless arrested, the arrest must be withheld. The arrest must be withheld, even if necessary. This is the clear and categorical judgment of the Supreme Court. So you don't have to be worried about the prospect of arrest. If any unscrupulous, uninformed, ignorant police officer comes and threatens you, you simply say, Jacob Matthew case. Take a printout, Google it, and give it to him. Throw it on his face. He will go back. Once he knows that you are properly armed with the necessary knowledge, he will go back. Now, This is with specific reference to Joseph Matthews cases with specific reference to the doctors to shield yourself from the unscrupulous and unmeaning and scurrilous threats of prosecution or arrest, etc. But there are two general decisions also by the Supreme Court again. The first is Lalit Kumari versus State of UP. This says, though Section 154 of CRPC clearly lies down, whenever an information about the commission of a cognizable offence is brought to the notice of the station house officer, he should immediately register. But in this case, a constitutional bench, after hearing the opinions of all the Advocate Generals, all the states, has stated, in certain cases, a preliminary inquiry can proceed. Marital discards, economic offences, like that they have given 4 exceptions, and registering a case against a medical practitioner also comes under this category. Please remember this. Number 1 is Joseph Matthews case. And then decision of the Lalit Kumari, decision of the Supreme Court in Lalit Kumari versus State of, just remember Lalit Kumari case, where you cannot hazily register a case unless you conduct a preliminary inquiry. What is that preliminary inquiry? I have told you in Joseph Matthews case, you should go to a competent authority, etc., etc. Then arrest. This is a case of Arnesh Kumar versus State of Bihar. Even in CRPC, the section 40 of CRPC, which is the general provision governing the principles of arrest, it says, if necessary, because under Anglo-Saxon jurisprudence, which covers the body of laws of this country, till proven, every person is a gentleman. Then why do you arrest and tarnish his image and harass him? Just because some allegation is thrown on you. That is the reason why the CRPC itself says, if necessary. But unfortunately, this is being observed more in breach. That is the reason why in Arnesh Kumar case, Supreme Court had ruled, and again this ruling has the effect of parliamentary enactment, that arrest shall not be made if the offence charge carries a punishment less than 7 years. And none of the offences that a doctor can be charged or a healthcare professional can be charged carries 7 years imprisonment or more. So you cannot be arrested. You understand this? So I repeat, gentlemen, you have to remember only 3 things. Specific to your profession, the salient aspects laid down in Joseph Matthews case, they protect you against scurrilous and uncalled for harassment of you by unscrupulous or unimaginative and ignorant people. People, sometimes unscrupulous groups, hooligans are now prowling on the streets to avoid paying fees to doctors. And if somebody dies for any reason, they would like to extract some money and have a cut of it. Second, then Lalit Kumari case says, just like that, a case cannot be registered. It should precede a preliminary inquiry. Third, Arnesh Kumar case, even if a case is registered, there are facts and cases to arrest the accused doctor. He cannot be arrested because 7 years. And one more point in this Arnesh Kumar case is, if police arrest inadvertently or due to some other untenable reasons, the magistrate shall not remand him, shall give him immediately bail. This Supreme Court said all the High Court should reduce this observations or dictum of ours in the form of a circular and circulate to all the trial courts throughout the country. So if any magistrate dictates it, he is violating it. You and lawyer can complain even against that magistrate. Unfortunately, it is a different case. That is the reason why they slap false cases. Recently on an MP, a sedition case was registered because it carries more than 7 years so that he can be arrested. So this is a question of playing wiser. Okay, so I repeat, gentlemen, please remember 3 decisions. Joseph Matthew case specific to healthcare professionals, Lalit Kumari case not to register the cases unless a preliminary inquiry is resorted to. Third, Arnesh Kumar versus State of Bihar. Some time back, I have circulated to some of the hospitals and nursing homes in country, including Dr. Krishnaiah, a memorandum of instructions issued by the government of Andhra Pradesh, undivided Andhra Pradesh, not to arrest. I requested Krishnaiah to trace it. I have unfortunately lost it to circulate it. Now, substantive provisions of law. These are some of the sections. Now, section 52, Krishnaiah has elaborated. You do it in good faith. Supposing a patient is brought I go and see somebody in unconscious road accident, I bring him. You treat in good faith. He dies. But if due care and attention is bestowed upon him, even if he dies, nobody can proceed against you. Because there, your intention was not criminal. You were not guided by criminal intent. So, but if you don't bestow good care and attention, etc., then even if you have treated him, then you will be guilty. Then accident, same thing I have mentioned it. Then 90, 91, 92 sections, they deal with consent. Lot of discussion has taken place, very, very elaborate. 337, 338 and 304, these are the only sections on which you can be charged. 337 is causing hurt, 338 is causing grievous hurt, and 304A is death resulting due to rash or negligence act. These are three sections, penal provisions, Indian Penal Code, on which an FIR can be lodged against a healthcare professional, etc. Now, slightly allied topic flowing from it is, as I told you in my preparatory remarks, I would like to, my theme is to assure the doctors. Now, the latest threat against doctors is violence, manhandling. So, 19 states have enacted various state acts. Popularly, by short form, they are known as Medical Protection Acts. But in spite of that, they cover all the discover doctors, affiliated institutions, as well as independent practitioners against attacks against physicians and damage to their property. These acts lay down jail term of 3 years and a fine of up to 50,000. But in spite, and similarly in this violence, really in the wake of COVID, government have issued an ordinance amending that epidemic act. And according to that, in COVID hospitals, in COVID related cases, if an offense is committed by the victim, if the offense is committed against a healthcare service professional, not only doctor, healthcare service professionals, or cause damage or loss to any property during an epidemic, it is punishable with imprisonment between 3 months to 5 years and a fine between 50,000 to 2 lakh. Of course, this is related to the ongoing pandemic. And it can be compounded also. In spite of all this, why assaults are continuing? Why? Why doctors are still on the streets agitating? It's because the essence of any law is in its implementation. Unfortunately, we are silent when it comes to implementing it. There is no depth of legal provisions. So similarly, in the parliament, we don't have a central act. Though health is a concurrent subject, only state governments have passed us. That too, only 19 states, as against 28 or 29 states that we have in the Indian Federal Union. So among the 19 states also, there is no. But in 2018 and also in 2019, there was a bill before the Joint Parliamentary Committee. It proposed imprisonment up to 10 years and imposition of 10 lakhs for any damage or violence against any healthcare professional or healthcare institution. But unfortunately, some quack or truant in that mind said, why a specific law only for doctors? It should cover all professionals. That gentleman lacks the common sense. The doctors are a class by themselves. They stand on a different pedestal. This has not been done it. Anyway, now what I feel is the interface between the police and the healthcare professional has to be widened. There must be a big gap. People aggrieved with healthcare professionals or healthcare institutions should not be able to run immediately to the police. This safeguard, if is grounded, then doctors can work confidently. For that, what is needed is, I give an example, I take a cue from this PNSDT Act. Prevention of Neonatal Sexual Determination Act, people cannot go to the police station. A competent authority has been designated another authority. In the state of Andhra Pradesh, it is DM and HO. He can either conduct surprise checks or he can receive complaints. Only when he is satisfied after due inquiries, then he will go to the police to take cognizance of this offense. Only then police come into the picture. Something similar to that, something of this kind is needed for medical negligence and also for violence or assaults against healthcare professionals or etc. The central government has to incorporate it. That is the reason why I said in the way forward, we are looking at it as if it is the issue of the doctors. No, it is not the issue of the doctors. In the patient care ecosystem, The doctor-patient relationship is not limited to the patient and doctor. There are many stakeholders. It is a social issue. It is an issue confronting the society. If a noble doctor, you're all noble doctors, if you are worried, if you are diffident, how can you treat with confidence another patient? It is a social issue. That is the reason why there are many stakeholders like society, medical institutions, faculty, managements, governing agencies, financial agencies such as insurance, education, medical loan providers, and public sector institutions, all these people have to come together and lobby. But unfortunately, I am sorry to say, your professional association, IMA, is a toothless body. It is highly politicized. It's not able to do anything. They fight for elections. Instead, it should work like a professional body. Hence, what you have to lobby for is a central enactment with a competent designated authority, as has been provided for in this PNS DT Act. Only then it can happen. I wind up, gentlemen, you don't have to worry about it, provided you are aware of it. I will again take you back to my homily of traffic rules. If a driver is aware of traffic rules, the tendency to violate traffic rules will be minimal on his part. And even if he is caught for not violating by any law enforcing agency, he can confidently confront. Hence, be aware of it. You have three safeguards. Only remember only these three. Even at the click of the net, Joseph Matthew's case, safeguards provided by the Supreme Court. Lalit Kumar case, nobody can register a case against you immediately unless a preliminary inquiry is conducted by a competent authority. C, you cannot be arrested unless the offense charged is for 7 years and above. It carries a punishment of 7 years and above. With these three things, I would like to sum up, and I thank the organizers for having given me this opportunity. And I'm based at Hyderabad. I know several people will be aware of our things. That is the reason why I have given you my phone number and email ID. Should you need any assistance, please remember my phone number for any clarification or for any intervention in any police agency. Though I am superannuated by virtue of my having been a faculty member at the various state police academies, including National Police Academy, I am in live contact with police officers, right at the cutting level to the supervisory levels. So I will be able to intervene. And the tendency on the part of the field police professionals to harm you, I can minimize and I can intercede for you. This I will be happy to do it. So please note down my number. I would request Dr. Srinivas Kasha to circulate my name and number. Should they feel any need for it, they can access me always 24/7 or via Dr. Krishnaiah, my best friend. Thank you.
Thank you so much, sir. That was a wonderful talk and your reassurance. Thank you so much. And without any delay, we'll go ahead with the panel discussion part because we are already out of time. Dr. Krishnaiah Garu?
Yes. Can you hear me?
Yes, yes. But we cannot see you.
Host disabled. Yeah, that was a very elaborate discussion. Host disabled participant screen sharing. Can you?
Yeah, I can. Just a second. Yeah. You are actually using two devices. That's the reason they must have done that.
All right. Yes, we had a very elaborate discussion, definitely. You know, going into the nitty-gritties and lot of details and case quotations, it is for the lawyers to convince the judge to make a decision. But an average orthopedic surgeon, I hope that at the end of the day, giving all these detailed versions, they have got the principles. They understood the principles of medical negligence.
Have you got it, sir? Not yet?
So therefore, just coming on to that.
Yeah.
So since we're, we have exceeded time, I have just, I cut it down to simply 2 questions, which probably more relevant instead of going into the details.
Have you got the access, sir, to share the screen?
Not yet, Kasha.
In the lower part of your screen, you have green share screen option. Just working on that.
Okay, am I online now?
Yeah.
Okay, so for the paucity of time, we just wanted 2 questions put to the panelists. One important, Dr. Nagpal, as you heard, that has extensive knowledge in this field. So I'll just put one question. I'll start with him. Medical.
One addition, we have one insurance person from Apex Medical Insurance, Indemnity Insurance, Rajesh, who is also there.
All right.
Also
Okay. Let me start with Dr. Nagpal. I mean, you've given a wonderful, very detailed account on this. But as I said, average orthopedic surgeons, I don't think they have time and patience to go through all the case details and pick up the nitty-gritties. So at the end of the day, the purpose of this webinar was to give some brief, silent principles, perhaps single point, one sentence answers to our audience so that they understand the basics of medical records. The subject was spoken very widely at length, perhaps more suitable for practicing lawyers and legal students. Dr. Nagpal, when you do, you're an endoscopy specialist, and we also do arthroscopy and things like that. Is it a mandatory that you record all the time? First question.
No.
And do you need the permission in case without name and other things, if you want to present that in a conference?
Yes.
And patient case details on the hospital. You mentioned that one judge, one high court has mentioned to put it on website. We understand it's a highly confidential subject, and only with the permission of the patient, you can release the record. If some ex-relative comes and says, I want to have the record, I know our understanding is we are not supposed to give unless with the written permission, including to the lawyers, except to the judge or sometimes to the police. Please comment on that.
So you do not need to record all endoscopy procedures. That is the answer to the first question. You need permission of the patient in case you are recording for academic purposes to present in conferences, but there also you have to shield the patient's identity.
So sorry for the interruption. Even if you shield the identity, we put, mask the face, etc., etc. Still you require the permission?
Yes, yes, you still require the permission. Number 3, patient case details on hospital website. This is something Medical Legal Action Group has been keeping as something we need to challenge in a special leave petition in Supreme Court. This is not practical in India, and we do not have the resources, and this is not the focus for small and medium healthcare establishments to update their website on an hourly basis. Right. This is something which is not practical, and in case this case law becomes applicable on doctors, definitely our group will be challenging this in Supreme Court.
Yes.
Is it not confidential and not for
question on that? In an institution, it's all right. You have the whole team of doctors. You are doing the procedure and somebody else. I mean, like in England, even when they are resuscitating, somebody is exclusively there in the team only to document. But unfortunately, in our situation, it's a very impractical. I think you mentioned already. However, for a smaller setup, going and documenting and recording all the nitty-gritties is such an unpracticable thing. I mean, what would you say to this?
So that is why I'm saying extrapolating the British law or the US law in a country like ours, When we are talking of such kind of persons who can simultaneously document, we also need to pay these persons, which also means our charges also will start matching the US and UK charges, which is not the situation here. In India, you can get a coronary artery bypass graft done in $2,000.
So what's the answer? What is the answer? I know, I mean, you raised it, but how do we connect this when it comes to, litigation? Unfortunately, they don't care, how much you charge.
The problem is in India, doctors are kings in their castles. They do not form an army to fight a particular war. They are all small kings in their own castles. And unless and until we get together, have a voice which will be heard in proper places, health is still not a political issue. Maybe COVID will change this. This is not an issue on which elections are fought. And IMA or any other medical body is not so proactive as to have
take it up.
What should I say? A voice in where regulations are being made. Because we send our representations to the government for any new law which is being formed on healthcare issues, but usually it is discarded in the dustbin. It has to come from.
Let's hear from Professor Madabhushi on this. Sir, you are still there?
Yeah, I'm there.
Yeah, can you throw some light on that, on these points? I think Dr. Nagpal, is an expert on medical documentation, and you also, I'm sure, as a part of your judgment recently, you shared that with me that you must have gone through quite a bit into the records. Okay, leave aside the first two questions. We want your view on, the court has directed, put all the information on the website. Is that possible and is it acceptable? I mean, it's a confidential information.
It is not correct because the patient's information is patient's right, not right of any other person. So patient's information has to be given to patient, and on his request or in the absence of the patient, or if he's not alive, his legal representatives have to be given that information. But giving it to third party arises only in the public interest. And in every case, it is not public interest. So there is no question of automatic uploading of medical records on the website of any hospital. Nobody mandates it. And if somebody does it, it can be challenged on the grounds of privacy. And right to privacy in 2016-17 has been established to be a fundamental right, and you cannot violate it. This kind of uploading the patient records on hospital website is a blatant violation of privacy of patients.
So that's the point I'd like to make. We've discussed a lot of cases, right? No, here the High Court, directly High Court itself had made such a kind of totally illegal and unaccepted kind of statement. We can't take that as a precedence, right?
It will go.
I want to make this
1 minute.
I want to make this point in here. We talk about principles. We talk about generality rather than one particular case, although the case was discussed for understanding purpose. On the same note, I will close this topic up by saying one. Dr. Nagpal, often the insurance people, there is the insurance man right there. Insurance people take away the records. For example, our discharge summary, they take away original, they take away the x-rays. So when they come for our follow-up, hey, where are the previous x-rays? They are with the insurance. So we cannot compare how this fracture is healing, 6 weeks ago or immediately after surgery, 6 weeks later. And now, Srinivas, you following this?
Yes.
So therefore, I think in England, they don't give it. Insurance have right to take copies of it, have access to information and hand out to the patient. But in this country, that subject is not scheduled for them to process their claims, whatever. They take away all these originals, not photocopies. So just Dr. Nagpal's comment on that quickly, and then our insurance.
So X-rays now should be given, digital X-rays, a digital copy should be given. It should not be the films which are given. Films are the property and the right of the hospital to retain unless asked for by the police. That also under signature, they will be making a written request and receiving whatever is handed over to them or from an order from the court.
Absolutely, there you are. So that applies to hospital cases. Sorry, I forgot your name, sir, insurance person. Can you just say that, is it mandatory you must take all these things and retain in your records for processing your claim?
Mr. Rajesh.
Hello. Hello.
Yes.
Mr.
Hello.
Rajesh.
Yeah. Can you hear, sir?
Yeah, we can listen. You are audible, sir.
Yeah. Good afternoon to all. And I am thankful to.
We got two more questions.
Yeah.
Please say 2 sentences.
Yeah. I am thankful to Somashekhar sir for inviting me, and all the good afternoon to all. Actually, I am not an insurance guy. We are a risk management company, Apex Insurance Consultant Limited.
All right.
We are a corporate agent for insurance company, but we give service to doctors and hospitals all over India. 23 states we are operating, and in Telangana we have a strong base.
Just answer this question: whether do you have to have originals or not?
Insurance companies do take nowadays the originals. So what is their idea about that? Actually, I also don't know, because I am not an insurance guy. I am a risk management consultant. We provide the insurance from the insurance company. We are a corporate agent for insurance.
There is small correction, sir. He is not from insurance background.
Right, sir, then we'll stop that. We'll go to the next question. Thank you very much. The next question is...
one thing, sir, I want to say on this platform, we are providing the legal service to doctors and all hospitals.
All right, sir, we'll certainly take that. Let's have the question on, another burning question. I think Mr. Damodar has very nicely briefed up about it. When it comes to compensation, civil liability, okay, you have time and you have people to argue on that. This is the thing that worries everyone, especially our friends in the rural area, as solo practitioners, where I just give you this hypothetical situation. Mr. Damodar, you're listening? Patient died following a complex and major surgery in a nursing home, let's say after a major accident. Now, quite usual. And the relatives bring local politicians and put up dharna in front of the hospital demanding huge and unpaid compensation. And they even go to the police station to strengthen their case. And you have one Dr. X, orthopedic surgeon, there in that hospital, and this poor guy. And police come, and the pressure on this doctor is much higher. All your loss, Matthews, on the 2 other cases, he can't just argue with that. And there are 2 possibilities. Either they arrest him, which is less now, but now they force him, they arm twist him to agree for heavy compensation. Sir, what is your advice to our members, Mr. Damodar? Hello?
Sorry, legal position is, as I have
What is your advice? What do you think our average doctor should do?
Yeah. People coming and demonstrating and threatening with the dead body, etc., is not provided for in law, but they are doing it. The way law is being contravened in every part of the country, that's not correct. That is mere demonstration of muscle power. The police should come and tell them, this is not the way for you to do it. You should lodge a complaint with DM and HO, etc. They will explain there is negligence, and then we will take a case. They have to come and disperse it. For example, if some people go and do a demonstration in front of the chief minister, for example, the other day nurses were doing it. They are being dispersed. The same thing holds good even for healthcare professional. But unfortunately, either due to ignorance or due to some other reasons which are obvious to you, police are not able to do it. That is the reason why, and police sitting and forcing or rather mediating with the hospital personnel to make some compensation, etc., is also prescribed by law. It's not just permitted by law. The correct way is this only. It is just correct. On the other hand, the agitators are guilty of vandalism. Correct. But what happens is, in our country, for example, traffic rules, many a time pedestrians violate. The driver of the vehicle is not guilty, but the sympathy is on the part of the pedestrians. The sympathy is on the part of the injured. The sympathy is on the part of the deceased, even though he is a violator of law. The same spirit is holding good. That is the reason why lack of civic sense, lack of awareness is needed in this country.
So what's your advice on this, when you say a situation like this, which is not an unusual situation quite frequently, just in one sentence, I'll ask the opinion of other.
Yeah, recently, after the COVID issue, the government of Telangana recently have issued directions and the Director General of Police also come online, has issued a press statement, etc. Such things are not permitted. If you have anything else to do, come to the police station. Don't go to the hospital.
Excellent.
Don't go to the hospital.
Sir,
Come to the police station. At the police
Vijaya.
station, they will make them sit and tell them, okay, give a complaint and advise them, you go to the designated authority, that is DM and H or somebody. I will also forward. It
All right,
has
sir.
to be treated as a non-cognizable offense till cognizance of it is taken by the court. But unfortunately, the law is not categorical in our country. It is an evolving subject.
Let's hear from Professor Madabhushi. Sir, you want to add anything very briefly?
Yes.
As I said,
yes.
simple, straightforward answers would help us for people to
In my
capture
view,
this and understand
in
this.
my view, the hospital management should not expose the doctor to the people. First of all, that is the protection required. Second, the material, the records, if they are very clear to show that what treatment they have rendered is correct, and that should be given to the politician. That should be presented to the police officer to convince that there
But
is
it
no
doesn't
negligence
work
on the
that
part
way.
of
They're not, they don't, those logic and rational doesn't work. I mean, this is a practical.
I should complete my answer. I should complete my answer. See, as Mr. Damodar said, for a muzzle display and vandalism and illegality, you have to act according to your common sense on that point. But speaking, I'm trying to prevent by saying that if you have wonderful record, transparent, honest record, which can be shown to the politician or to the police, it has to be done by the management of the hospital, not by the doctor, because they're emotionally vulnerable. So that has to be taken care. But if somebody comes and attacks, only police action and only immediate complaint is the remedy.
All right, sir. Dr. Nagpal, you want to add anything quick on this, please?
Sir, any compensation which you pay out of court under duress is at times shown as proof of your negligence when a case for consumer court is filed. Right. Do not ever fall for this. Do not ever make any payment under duress, because any agreement which you sign over there, we have umpteen number of cases that the same agreement has been taken and shown in consumer court. Ki, look, this doctor was negligent, hence he paid us 1.5 lakh rupees. Now we are demanding 20 lakhs.
Excellent. That's a very nice and loud and clear message. Dr. Vijaya Bhaskar wants to say something.
Sir, regarding the case sheet, the insurance company is asking Xerox copy of case sheet. So, can we give a Xerox copy of case sheet to insurance
different
companies?
question. I mean, I'll speak on this question. I mean, instead of going back again.
Okay.
Anything you want to add on this question?
No, nothing, sir. That's all.
Thank you very much for the wonderful answers. I'll just go through one more question. I think we are running out of time. This question relating to, I think, yes, Dr. Professor Madabhushi. Sir, another, of course, burning issue apart from criminal negligence and the civil negligence we have discussed very detailed. Is doctor liable for negligence of hospital? I mean, there is a prima facie evidence. The doctor, every party has done well, but he works in a hospital, which we all do. And then, the hospital didn't do something wrong in the course of the treatment. Their representative, their employee nurse. So what is the liability of the doctor in this particular case?
There's no liability. There is no liability of the doctor. Nagpal, he is not responsible.
We'll come
Absolutely
to that in a moment,
not.
sir. I know there is a liability. There is a liability.
There is no liability. There is no liability if there is no negligence.
Sir, let me elaborate the question. But when the case is filed, it's a combined liability. I mean, to start with. But as far as the legal perspective, doctor is not liable. Is that what you're saying?
Let me say it. Let me answer it completely. My point is, in every negligence case, whether it is civil or criminal mostly, they will apportion the liability according to proof. So if records clearly show that a doctor or a nurse or somebody else is not negligent, he will definitely not be made liable. So it depends on how you establish your honesty, your absence of negligence. But if there is a combined impact of a little fault of doctor, a little fault of nurse, a little fault of other post-operational or some other kind of a treatment or activity or conduct of procedures, then there will be joint liability. A doctor can extricate himself from the liability of the hospital if he can prove that he is not responsible for it, and it is the duty of the doctor to prove so. To do that, he will have his own record will help him.
Very well, sir. Thank you. I think Dr. Nagpal, yes, I mean, I'm sure you must have had so many cases of this kind of situation. Just try to be
number
as
of
brief as
cases.
possible, sir.
Classical example is Spring Meadows Hospital case, 1997. A nurse gave chloroquine injection IV instead of chloramphenicol, which the pediatrician had ordered. Now, this was a classical case where the nurse was at fault, but the hospital as well as the doctors were held liable. There is something called vicarious liability in civil law. Yes. So vicarious liability is of the team leader. And the team leader cannot automatically be exonerated for a fault of a junior within the team. Of course, circumstances of the case will vary, and there will be some incidents where this vicarious liability will be applied, some where it will not be applied. But fact remains, we cannot automatically expect the doctor to be exonerated where a fault is of the nurse.
So,
not qualified.
To sum it up, it's the burden lies on the doctor to prove himself that he is not party to it, because this particular nurse's respondent superior is the hospital, because she functions and works exclusively under the purview of the hospital management, which unfortunately not many people know the difference between a practicing doctor there and the hospital. When it comes to billing and anything, the first thing that comes is to the treating doctor, which has very little role and place in the whole scenario, except for his treatment, what treatment to prescribe and how to do that particular operation. He doesn't have any other thing to say, right? Anybody wants to add anything, faculty, on this?
Can I add one point?
Yes.
There are three kinds of liabilities: individual liability, joint liability.
Close to the microphone.
Yeah. Three kinds of liabilities: individual liability, joint liability, and vicarious liability. Depending on the intricacies and the action of the doctor as a component of overall treatment, the liability will be decided. If an individual doctor's performance can be proved to be correct, he can be extricated. If it is part of a joint activity and an integrated activity of the entire hospital, he also will be liable jointly. So it depends on the material factors of each and every case.
Very well, sir. Thank you. Kasha, do we have another minute or two, or you want me to wind it up?
Yeah, I want you to wind it up. We are already late.
Very well. Thank you very much for giving me this opportunity. I really want to thank all the faculty for giving on wonderful answers and participating on a Sunday morning. Spend 3 hours and helping our doctor community and enlightening them. Thank you very much, sir. Professor Sridhar and Mr. Damodar, Dr. Nagpal in particular, all the way. And our friend Joshi, you made him to wake up very early in the morning on a Sunday morning.
Nikhil.
Thank you. Bye-bye.
Thank you, sir.
Thank you so much.
Yeah, sir. Now I request Pixart people Pixart and Janssen people who are contributor for today's supporters for today's event. Pixart, are you there? From anybody from Pixart? Mohit. So just 1 minute.
Yes. First of all, thank you all the president and secretary of TOSA and TCOS and all the guest speakers for giving us an opportunity. It was definitely a very, very good learning experience to understand on the medical legal aspect. Just to brief you what Pixart is doing, Pixart is actually, the vision of Pixart was actually enable all the individual surgeon to have their own documentation in place. So like how we have discussed today, what is that, how the documentation has to be taken care of, what is that you need to keep medical records of. And Pixart is just a way of giving you your own personalized EMR system where you can save all your patient records at one go, right away from pre-OP to the post-OP, and have all your X-rays, CT scans, and every images saved under one platform, along with all your patient consent, which are the written consent, audio consent, and the video consent saved under one single platform, so that sometime if you're even switching over the hospital, the records, the patient records are still with you and you have the complete ownership of your records. Thank you so much. We would expect everybody to actually have a look at that particular platform, and definitely we are always open for the feedback, if anything.
Thank you so much, Mohit. He's from Pixart. So I want Janssen people to come on.
Yes, sir. Yes, sir.
Yes.
Good morning, sir. Good afternoon, sir.
Yeah,
sir, would you like
I'm
to
there.
speak, sir?
Yeah, Kishore. Kishore is there. Yeah.
Yes, sir. So very good afternoon to all the doctors. Thankful to TOSA as well as TCOS, and thankful to Dr. Kasha sir, as well as Dr. Somashekhar sir, and all the panelists for giving us the chance, Johnson, to be a part of this prestigious program. Thank you so much, Doctor, for being a wonderful program on this. Thank you so much, Doctor.
Thank you, Janssen.
And special thanks to Kasha sir for this wonderful opportunities for us.
Thank you, Purna. Sir, Somashekhar sir, vote of thanks from your
Thank
side.
you, all the faculty members. And this is what we have been hoping to conduct for a long time. And I'm so happy that ultimately it got into fruition. And I hope my fellow fraternity members get good use of it. And please do remember that this can be reached later on also on YouTube. So all the points you can check whenever you want. Thank you all once again.
Also on OrthoTV, sir. We should
OrthoTV. Yeah, that's true. So this is recorded and people can access anytime when they want. Thank you all.
So with this, I thank all the faculty, Janssen people, Pixart people, and OrthoTV people for your contribution. With this, we call it a day. Thank you so much. So
thank you, Doctor.
Thank you all.
Bye. Take care.